أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر صدق الله العظيم.
make them secure and equal.
तुम्हारा पिज्जा उकालना टाइप 1 शुगर वे मीठी जिंदगी तरफ में माता इंसुलिन नशो सुबह स्कूल तारा रवाना शु जवाद स्कूल सडेर शवकते और सलोड़म क्लास की सबक वेने
चौथी क्लास में था तब मुझे स्कूल भी अपनी छोड़नी पड़ी। मेरा नाम मुनीर अहमद है, मैं थरपारकर में रहता हूँ। मुझे 11 साल से डायबिटीज टाइप 1 है।
पेट साफ करना बीमारी कोन असां पंहिंजे पेट खे भांडो ऐं गोदाम बणायो आहे ख़ुदा साल में हिकिड़ो दफ़ो पेट जी सफ़ाई कयो अमा कोई ॻाल्हि।
जब मेरी तबीयत बहुत ज़्यादा ख़राब हुई तब हम हॉस्पिटल गए। वहाँ से पता चला कि शुगर है और शुगर की जो है इंसुलिन लगेगी।
पावर्टी की वजह से काफ़ी बच्चे हैं जो इंसुलिन परचेज़ नहीं कर पाते थे। अभी जो है मेरी यही कोशिश है कि थरपाकर के इतने दूर दराज जो है रेगिस्तान में पाकिस्तान का जो दूसरा कोना है, इसमें मैं इन सब बच्चों को मीठी ज़िंदगी के थ्रू फ्री ऑफ कास्ट जो है जो मुस्तहक बच्चे हैं उनको इंसुलिन डिलीवर करूं और जो है उनकी डायबिटीज़ कंट्रोल में रहे और ये सब जो है क्वालिटी लाइफ बसर करें।
The 5 pillars which form the basis of Meethi Zindagi were co-created and are being co-governed by the diabetes community and the health professionals together. These 5 pillars are access to medicines, access to quality healthcare, empowering self-management education, emotional well-being or peer support, and a supportive and enabling environment. The culmination of these 5 pillars is what Meethi Zindagi is.
आपका एक big thank you करना है हमें कि जो सर्विस आप जिस हिस्से में बैठ के कर रहे हैं, जिन रिसोर्सेज के साथ आपकी जो एफर्ट्स हैं ना, वो हमारे लिए इंतहाई वैल्यूएबल हैं एंड वी रियली रिगार्ड देम अ लॉट। वी हैव लॉट ऑफ अदर डॉक्टर्स हु आर कोलैबोरेटिंग विद अस अक्रॉस पाकिस्तान फॉर दिस कॉज एंड द वे वी रिसीव रेफरल्स इज टूफोल्ड। Whether the child is referred through an individual doctor or a healthcare practitioner in their personal capacity or through a hospital, the child undergoes a rigorous socio-economic status check by our team. if deemed eligible, the child goes on to the waiting list. Once they hit the waiting list, the insulin support starts. The ethos of Promise of Insulin Support Program at Meethi Zindagi is not only to give life or insulin to these kids, but to add quality to this life, both by manual and digital means.
Talking about digital means, Meethi Zindagi has launched Pakistan's first digital diabetes education web platform. इसकी खूबसूरती ये है कि इसको co-create किया गया है by people with type 1 diabetes and HCPs so that it's standardized, uniform and clinically approved authentic resource. पाकिस्तान के different centers में इस resource को embed किया गया है so that regardless whatsoever the socio-economic status of a person living with type 1 diabetes is, ये फिर भी सबके लिए available हो. We have also developed a book named as Setup, which is Pakistan's first structured education curriculum for people with type 1 diabetes. इस book के different modules हैं जो कि पाकिस्तान के different cities में 3 monthly basis पर workshops की सूरत में लोगों को करवाए जाते हैं so that they can learn how to better self manage their diabetes. जब हम टाइप 1 डायबिटीज़ की बात करते हैं तो हम बच्चों को नहीं भूल सकते क्योंकि ये कंडीशन सबसे ज़्यादा उन्हीं में पाई जाती है. So to empower and educate children with type 1 diabetes, we have developed a series of diabetes camps supported by Diabetes Education and Camping Association USA. इन camps में different fun-based activities करवाई जाती हैं by our trained peer leaders.
मैं मीठी ज़िंदगी के बहुत से पेयर लीडर्स में से एक हूँ और हमारा काम यह है कि हम पाकिस्तान की टाइप 1 डायबिटीज़ कम्युनिटी को एक ऐसी सेफ स्पेस प्रोवाइड करते हैं जहाँ पे वो अपने एक्सपीरियंसेस शेयर कर सकते हैं. फेस टू फेस इवेंट्स में हमारे टी डेज़ आते हैं और डायबिटीज़ कैंप्स आते हैं. इनमें हमने मल्टीपल एक्टिविटीज़ रखी हुई होती हैं और जो कि इवेंचुअली एट द एंड ऑफ द डे एक टाइप 1 मेंबर जो उनको अटेंड करता है वो बहुत लर्न करके जाता है. या फिर हमारे फेसबुक ऑनलाइन ग्रुप है जहाँ पे लोग अपनी क्वेरीज पोस्ट करते हैं, अपने एक्सपीरियंसेस शेयर करते हैं और नॉन मेडिकल इश्यूज़ वगैरह डिस्कस करते हैं.
अच्छा, अब आप सब मुझे बताएं कि हमारा स्कूल में आके आप सबको अवेयरनेस देने का, मालूमात देने का क्या मकसद है? ठीक है, आपके घर में किसी को है? पापा को, आपके भी पापा को. चाहे एक्सेस टू मेडिसिन्स हो या एक्सेस टू क्वालिटी हेल्थ केयर हो, एजुकेशन एंड एम्पावरमेंट हो या पीयर सपोर्ट हो, ये सब उसी वक्त पॉसिबल है जब एक इनेबलिंग एनवायरनमेंट प्रोवाइड किया जाए. मीठी ज़िंदगी is proud to step forward and to educate the children with type 1 diabetes because education is the most powerful tool out there.
No mean feat that Meethi Zindagi has been able to reach 85 plus towns and cities in Pakistan to deliver insulin and supplies for those persons with type 1 diabetes who need this assistance. And this has only been possible because of the generosity of the people of this country and from other organizations internationally.
like to share a few reflections of how you have seen the work to know and what you feel about it. So, by the time we just get the technical issue will be sorted. By the way, for those of you who don't know, Sundas is going to appear very soon on the screen as Fatma Jina. Let's go. Just take 2 minutes break, Sundas, and
Assalamualaikum. I'm sure a lot of people here don't know me because a lot of the work that I've done and me as a person has always been behind the camera. But I remember meeting work launch started in 2017, yeah. So it has been 6 years. 6 years. I was studying in NUST back then, studying filmmaking, and I just stumbled upon this project. I had a story to shoot in Lahore, and storytelling has always been something which is very, very close to me. I love, putting stories on camera and editing them in a way that would bring out the impact. I also wanted to be an actor and I wanted to be a commercial filmmaker, which is very opposite to this, which is documentary and telling factual stories. Why documentary? Because I remember the first story for me to Zindagi, which was what was the name of that child? Omaima was the first story that I did, and doing that story was so satisfying and it was so fulfilling because the reaction that it got, it was so impactful and it was so powerful that I felt very fulfilling doing that. And I just felt that maybe if not commercial films, telling stories or making an impact through documentary and actual stories which would help an organization that is doing genuine work and which would help children who actually need help, children with hypermobility. So that's something I feel that was a very fulfilling and very powerful thing for me to do. And that's when I decided that I am going to stick to Meethi Zindagi, and it has been 6 years. And we've been making stories, we've been traveling all across Pakistan, Thalparkar to the north, Mithi, Karachi, and I think one of the biggest supports here has to be my husband, Farhan. Thank you so much for sticking through thick and thin. And he has been there with me in the desert, all dirt with dust, in waters and everywhere, traveling in good health, sickness, everything. And thank you so much. I would really want to take this platform. It's a long speech I'm giving, but I would really want to take this platform to thank Meethi Zindagi for giving me this opportunity because this is something where I've actually found what I want to do and what I think I can do best, which is making an impact and telling stories. Thank you so much. Sorry for the long speech.
thank you so much for this. And this is what mothers do. So my mother really consciously gave me sugar now, she said me a chocolate, which I'm glad. Thank you for being there, Mama. Up now, give me producer. On this emotional note, I would like to welcome now Dr. Nidhi Kaur. Dr. Nidhi is joining us all the way from UK. She's a good mama. तो जब मैं आइडिया के साथ लैंग्वेज का प्रोग्राम कर रही थी हर साल ऑल्सो हैपेंस टू हैव टाइप 1 डायबिटीज सिमिलर एज तो एक बार हम डू मामा शी इज अ डू मामा बिकॉज़ यू रिप्रेजेंट डायबिटीज पेशेंट Nidhi is a board member in NHS Commission Trust. She is the director for Health for All Advisory and the past chair of the National Diabetes Federation Board. One special reason why Nidhi is here today with us all the way from UK is her family belongs to Rawalpindi interior area before the partition. I hope Nidhi, you are hearing me there? Yeah, okay. So Nidhi's parents belong to ये जो मोती बाजार राजा बाजार का एरिया है, यहाँ से मैं ताल्लुक था, and every time I meet her, she tells me, मुझे पाकिस्तान आना है, I want to go and visit my family. Unfortunately, that we have not been able to do that yet, but very soon we will get you here. And her father was a very good friend of Faiz Faz Shifa. So with that, I think हम थोड़ा सा अपनी लैंग्वेज में आ जाते हैं. मुझे अच्छा लगता है जब मैं इंग्लिश से लड़ती हूँ बाहर इंग्लिश में बात करते करते अचानक से we just started. It's always a beautiful connection. Nidhi is going to talk to us about universal healthcare today. She's a universal healthcare specialist. She's going to talk about this कि अगर हम अपनी health के ऊपर invest करें, how do we save? How does the government save? How do the institutions save? How do we do that? So please welcome Dr. Nidhi Paul with a big round of applause and let's get started.
Hello everyone, can you hear me? I guess you can. I'm really pleased to be here today. I'm just going to ask the host if they can hear me. Hi, everybody. I'm Dr. Nidhi Paul, and I am the immediate past president of IDF Europe, which is the International Diabetes Federation, as Sana might have told you. Sana is a lovely friend, so I'd like to say good morning to all of you. Salam alaikum. My parents, as Sana has said, my mom particularly, was from the Pindi area, and I would have loved to be here with you today. But inshallah, one day you will invite me again, and I will be there again. So I'm going to start my talk by telling you a little bit about what I mean by universal healthcare, and then just moving quickly on to what is value and what is value-based care. And you'll understand what I'm saying about value-based care and the contribution of PROMs, which is patient-related outcome measures. We'll talk about what those are and what is their role in achieving universal healthcare and value-based care, and how do you get quality in healthcare in place by using patient-related outcome measures, and what does it mean for people with diabetes and the care they receive. And this is a subject very personal to me because my son has type 1 diabetes and has had it for 33 years. We're a family that's lived with type 1 diabetes for a very, very long time, and I've been a diabetes advocate ever since. Could I have the next slide, please? Could I have the next slide, please? Yeah. So what is universal healthcare? It's when the government pays for your healthcare and you achieve, they may not provide it, but they do pay for it. And this is what's called the UHC cube. So it says, it asks governments, who do you cover? Who is covered under universal healthcare? Is it everybody or is it part of the population? In my book, it's everybody. How much is covered? So how much are you going to cover? Are you going to cover every expense that happens in universal healthcare, or is it some of it? And who is covered, how much is covered, and what is covered? And that is also really important to people with diabetes, because are they going to cover just basic medicines? Are they going to cover certain types of insulin, or are they going to cover everything? Are they going to cover the new pumps? They're going to cover the looping systems? Are they going to cover CGMs? What is it that they're going to cover? And in many Western countries, that is still up for debate. We say we have universal healthcare, but for example, in the UK, we've been fighting for every person with diabetes, type 1 diabetes, to get CGM, and we only just managed to achieve that last year. And now this year, we've now got NICE to agree that we will be getting looped pumps for everybody with type 1. So even in a country like the UK, where we do have universal healthcare and it's paid for by the national payer, there is, what is covered. Could I have the next slide, please? Somebody moving my slides. Could I have the next slide, please? Yeah. And then I just want to talk to you a little bit about what value-based care is. And this is really important for PROMs because value-based care is based on patient-related outcome measures. And that's the definition that the University of Oxford said in 2019. It's the equitable, sustainable, and transparent use of available resources to achieve better outcomes and experiences for every person. So please note better outcomes and experiences for every person. So it's not just about how much care is delivered, how many times you went to the hospital, how many times you saw your doctor. This is about how you felt that care was, and did you get better with that care? And it is the aim of organizing health services to provide the best possible outcome for patients while optimizing costs. And you might find this odd, but you can carry on paying for lots and lots of activities and the outcomes are not great. And when you find systems that go towards value-based care, you find that the patient experiences better care and the outcomes are better as well. And most healthcare providers will receive their income based on activity. How many times you went to see the doctor, how many appointments you had, but not what outcomes were achieved. So you may have been to see the doctor, they saw you for 5 minutes and you were out of the door. That didn't really achieve very much, did it? But the provider still got paid for it. So, and then it flipped to how beneficial it was to the patient. And there are many systems in the world that are starting to do this. Next slide, please. And the next thing is, if you look at what the foundational principles of this is, in the middle is outcomes over costs. And a lot of actually pharma companies are moving to this. And a lot of governments are saying to pharma companies, like the manufacturers of insulin, like the manufacturer of many diabetes drugs, and they're saying to them, we're going to pay you, but we'll pay you based on outcomes. And that means that the pharma companies have also got to start to organize themselves in a way that they deliver good outcomes for patients. That might mean adding to their sale of insulin or something else, a diabetes management program, for instance, and tracking that to see whether their medicine or their drugs actually made any difference to the patient. It's very data driven. So many countries don't have this data. And I know that Sana and Meethi Zindagi have been advocating for collection of data. And I know Meethi Zindagi has quite a lot of data. And this is to support evidence-based policies to support the transformation if you don't have the data, you're not going to be able to know whether those outcomes were better or not. And this also requires some legislation and some regulatory approvals for this to happen. And I'm not sure where you in Pakistan are in that journey. I know that you had started that journey some years ago when I did some universal healthcare work there. So it requires informatics. It requires some benchmarking tools that I'll talk to you about in a minute. It means what kind of payment are you going to attach to it? How much are you going to attach to it? And how is the delivery of this going to happen? And that will require different roles and different ways of delivering some of this care. Next slide, please. So, and then I'm going to just move to PROMs and how PROMs contribute to value-based care. And PROMs and PREMs are two things that are being talked about, not just in the medical world, but in the patient advocacy world quite a lot. And I'm sure you'll have a discussion about this later. I'm sorry, I can't see the room and I can't see how you're taking this this conversation. So PROMs are patient-related outcome measures, and there's another measure called patient-related experience measures. Both go hand in hand. I'm going to just focus on PROMs for the moment. And they're a critical component of whether clinicians are improving the health of patients. And unlike process measures, the process measures would be how many patients did you see? How many of them had their HbA1c tested? How many had their blood pressure taken? That's process measures. But PROMs will be focused on, did you adhere to the standards of recommended care, or did you measure patient experience measures which focus on care delivery, such as communication? How did you communicate with your patients? And PROMs attempt to capture whether the services provided actually improve patients' health and sense of well-being. They may be asked, patients might be asked to assess their general health, ability to complete various activities, mood, their fatigue, all sorts of things that contribute to your quality of life, not just your HbA1c or your blood pressure. So your PROMs focus on functional outcomes, and this resonates really well with patients. We know that because my son has type 1, as I said, and this is what he wants to feel. He wants to feel better so he can do a job, he can go to work, he can look after his family, and he can interact socially. That's what matters to him. It doesn't just matter what his HbA1c is. Of course, the HbA1c contributes to that. But if he's not feeling better about it, then there's no point, is there? Next slide, please. And the views of patients have been sought outside of clinical trials for new drugs or medical devices. And they have rarely been sought, actually. So, somebody might ask you, will this medicine work for you? And there may be a clinical trial on that. But then there are not many objective measures of how that made you feel. So the ultimate measure of a health system that's working well is whether it helps people recover from an acute illness, live well with the chronic condition, and face the end of life with dignity. And people's reports, I believe very firmly, are the only way to gauge success. And I have worked in over 44 countries now on universal healthcare. And I've been to many low and middle income countries. I've worked in high income countries, but mostly in low and middle income countries on implementing universal healthcare. And I believe governments should take this into account when they're setting out their UHC standards. Next slide, please. So how are PROMs used in health service delivery? They're expected to play much more of a prominent role. Could you go back to the previous slide, please? Thank you. Yeah, they're expected to play a prominent role in assessing performance, comparative effectiveness of different treatments, and that will gear pharma up to pay more attention to how you are feeling, how people with diabetes are feeling. Incorporating PROMs into meaningful use standards. So, many countries will say, did the doctor perform anything useful? Is they call meaningful use standards. And how you capture data as well is called meaningful use standards. And it is likely to prompt more use if that's how you're being assessed on your performance. And it's also expected to be used to benchmark the performance of healthcare providers. So how is one doctor doing against another? We certainly have that in the UK. It's called the Friends and Family Test. Would you recommend this doctor to somebody else? And this is in the public system. Next slide, please. And then you have the types of patient-related outcome measures. And I'll just touch on this briefly. If you want to ask me more questions about this, quite a busy slide. If you want to ask me more about this, please do in the question and answers. I hope I'm going to leave some time for that. And there are categories of this. This is health-related quality of life. These are surveys which are called HRQLs. And I'm not going to go through all of them. They may not be considered sufficiently specific, disease-specific to construct. There's functional status, how are you feeling, ability to perform certain activities, symptoms and symptom burden, which is the diabetes distress score type of things, and you might have heard of this, and health behaviors, which is a specific type of behavior that measure the frequency of your behavior, and patient experience. And this will be concerns with satisfaction with healthcare delivery. It will be reflecting your actual experiences with healthcare services, and fosters patient activation. So there are these are the PROM categories that people are starting to use, and there are some of the main strengths and limitations and what the characteristics of these are. These are quite detailed. There's a lot of academic literature on them, but I'm not going to bore you to tears on this. I'm just giving you a snapshot of what a patient-related outcome measure might look like. All of this requires activated patients who are contributing to this. Otherwise, if you don't contribute to this, then there's no point. The data is not collected, and the health service, the payer, can actually get away with anything they like. Okay, so next slide, please. And, this is the current situation. So PROMs and patient-related outcomes and patient-related outcome measures are a lottery at the moment. Some places have it, some places don't. And I'd love to hear from you, Sana, and from Meethi Zindagi, how your health system plays this out. Not just in the public sector, but how does this play out in the private sector too? Because it's really important to those guys as well. And then the future is that there's one set of PROMs, and that's to be used by all, particularly in the diabetes world, we'll come to that. Disease-specific symptoms, general symptoms, functional status, general health perceptions, and overall quality of life. So this is what should be in there, and that's the future. So next slide, please. So this is what a diabetes-related PROM set might look like, because this is picked off the National Health Service here, and this would be the individual characteristics at the top would be captured: the race, education, diet, exercise, self-management, medicines adherence, and positive attitude. How are you feeling towards your illness? And then biological and psychological variables. So those also come in there. It's not just, I'm measuring experience, but I'm also, some doctor might make you feel really lovely and actually do nothing for your diabetes. That's bad as well. And the symptom status is, worrying about hypoglycemia, blurred vision, depressive symptoms, anxiety, worry, diabetes distress, fatigue, pain, sleep disturbance. all part of your symptom status, but very functional about how you're feeling. And then the functional status, are you dependent on somebody? How is your mental function? How's your social function? How is your, as a team member for something, what's your role? How is it feeling? And how's your cognition? Are you able to think straight? Are you able to make decisions about your life? And then general health perceptions, overall quality of life. And then support from others is also part of your PROM measurement. As you can see, it's quite wide, and it's very rich and full of data, and that has to be captured if you're really starting to do PROM seriously and you're putting this together into patient experience. This will also require patients to say what matters to them. Next slide, please. And this is just a kind of a one that we did in the UK. It's called the Asian Diabetes Quality of Life Questionnaire, and it was based on discussions with people living with type 2 diabetes, and it had 5 subscales, and this has been applied in the UK. It's on the Diabetes UK website if anybody wants to look at it, and it includes financial aspects, interpersonal relationships, memory and cognition, diet and eating habits, and energy, and all the subscales that are important to individuals. This was developed in conjunction with people living with diabetes. This wasn't made up by somebody sitting in a dark room. So as you can see, these are and how they're interrelated and relate to contextual factors helps to select relevant outcomes. And then people can say, is this really relevant? This service really relevant? Is this sensitive to the people that are living with diabetes? Next slide, please. And then there's a set of people in Europe, across Europe, called ICOM, and a lot of people have paid attention to them because they are looking at outcome-based measures for diabetes. Particularly, they started with diabetes. These are the domains that you see on the left-hand side that people have used for diabetes-related outcome measures. So they have a whole bunch of stuff. So they include diabetes control, it includes health services, it includes survival, it includes chronic complications and active events that are happening to you, but also has a piece in there that includes patient-related outcome measures. And this is psychosocial well-being, diabetes distress, and depression that's measured. So that's what ICOM have put in their measures, outcome measures, and they put this across Europe to look at whether this is working, if services, medicines are working for people with diabetes, and if the payer is actually achieving what they should. Next slide, please. And this is, they looked at key domains that should be captured using PROMs and were important to people with diabetes and those involved in clinical care of diabetes. And this included self-reported health, so how you report your health, mental health, the impact of diabetes on multiple aspects of quality of life, including diabetes-related emotional distress. And you guys might want to talk about that while you're together in a room. The symptoms, treatment burden, and the impact of hypoglycemia. And you all know this. We as a family have experienced this. It is the most terrifying thing in the middle of the night to have to wake up to your child having a hypo. And it's very scary when your kid's gone and I can remember those incidents well. They're etched firmly in my mind. On a trip to France, my son had a hypo and passed out in the bus. And no one knew, and only his one friend knew what to do with it. His teachers didn't know what, they were all panicking, but his friends knew because they'd seen it before. But I know how it made me feel. It's a terrifying risk that you take, and you feel totally out of control. So it's those sort of things that make you feel, those are the things that you put into a set of how you're feeling about this and what that means to you as a family, as a person with diabetes. Next slide. You'd run your blood sugars high because you don't want to get hypoglycemia. So 3 instruments were recommended for annual measurements of patient-related outcome measures. One is the WHO Wellbeing Index for psychological well-being, the depression module of the patient health questionnaire. It's called the PHQ scores, and the problem areas in diabetes scale for diabetes distress. And that's called PAID. And PAID is a very nice way of actually measuring diabetes distress. Do look at it if you want to push your payer in trying to look at it. The next slide, please. And this is the questionnaires to assess emotional problems in people with type 1 diabetes, so very particular to type 1 diabetes. One is paid. Then the fear of hypoglycemia, depression in PHQ-9, anxiety, so generalized anxiety disorder questionnaire, and eating problems. So this is DEPSR, and this is a 16-item scale. So you can use any of these for type 1 diabetes. I like the diabetes distress one and the fear of hypoglycemia and the depression one, and that's what ICOM have used. Next slide, please. And this is the views of patient advocates. And, it's really important because if you don't use the co-creation with patient advocates, we found that out in many countries, if there's no systematic or effective method for communicating what happens outside the clinical encounter, such as perceived needs, symptoms, response to treatment, undesirable side effects, and effects on function, and this is what matters to patients, then, it will not be effective. The treatment will not be effective. And PROM systems have the potential to enable improvements by providing information that bridges the gap between the clinical service and the patient world. So it's also triggering the next right action. That's how you trigger the next right action. And the PROM systems have to be co-developed by patients, public, and professionals to maintain maximum value. And they should be integrated with the rest of your healthcare information. And patients should be able to use this information when they want to choose to use it. So this is how I would see how patients advocates could contribute to PROMs and how it should be used in real life. Next slide. I'm nearly finished. These are my conclusions. So again, a busy slide, but my conclusions are that countries developing PROMs and PREM programs need to mandate national consistent measures for survey programs. So you need to have one national benchmark. Otherwise you can't benchmark yourself. You can't say in Pindi, this is the service, and in Lahore, this is the service, when you're not measuring apples for apples. So health systems, both independently and collectively, need to establish clear priorities for using PROMs. And that is difficult sometimes to get governments to even think about it. And additionally, consideration should be given to how PROM and PREM data can form the basis of value-based funding. And this is how you fund healthcare. So if you use these PROMs, that's how you will fund it. And then providers have got to pay attention to it because that's how they're funded. If they're not funded like that, they're not going to pay attention to it, right? There's no incentive for them. And then it's imperative to identify and implement internationally agreed consistent care PROMs and PREMs. So you can push people, you can benchmark countries on how they're doing. Certainly that's how we've used it in Europe. And public reporting of data should be prioritized. It should be transparent, and consumers should be able to use it and to be able to use the part of that to advocate for better services. Thank you very much for listening. Any questions, I'm happy to take them. I can't hear you, Sana. You're on mute, so I can't hear you. I can't hear the room, guys.
Oma, can you please check? We cannot hear you.
I can hear you now.
You can hear me now?
Yeah, I can hear you now.
Great. So thank you so much for this very pertinent talk. और हमारा जो आज का theme है diversifying healthcare, integrating the various stakeholders, and putting people with diabetes at the forefront of everything. It relates so much to that. So you asked me a question about how we're using PROMs in our public or private healthcare. I would really want the audience to comment on that. Have you ever seen Pakistan में कहीं patient reported outcomes को prioritize किया गया हो by different policy? Dr. Hena, you want to say something? You have to come here on stage.
Hello, thank you for an excellent talk. I work as a GP in India and I work in Pakistan. I work across 2 countries, and every word you stated, particularly universal health care, or what we call it universal health coverage, made sense. Now, consider a country with non-existent, non-functional primary care, which is the case in most low-middle-income countries. So, what advocacy can be and where the starting point can be, it is a major task. Yeah. But things are in progress. Sensitization has taken place at the central level and provincial levels. But training and teaching of general practitioners still remains as a low priority with the stakeholders and policymakers. That's the bottom line. But thank you for an excellent talk.
Thank you. And it's true. I really agree.
Any questions somebody wants to ask me? Sorry, Dr. Nidhi is trying to say something.
So I am a primary care doctor, and I totally agree with the last comment. If your primary care physician doesn't know what's going on, then it's no good, right? You can walk in and ask your primary care doctor, I need a pump, and if they know nothing about it, what you're going to do about it?
Thank you, Reverend. Comment? Any questions somebody wants to ask me? I have a question, maybe, and it may be a bit challenging to answer that. How do you start on this path?
How do you start?
How do you advocate for this? Where do you start? What's the starting point?
Yeah. I think you start with getting your own data, because the government will not have the data. So if you're starting on the PROMs and PREMs measurements, you look at what you want to collect, and Meethi Zindagi advocates your users to actually go and ask for that data from your you ask your patients, you ask them to fill out those questionnaires, collect the data, and take it back to government and say, this is how patients with type 1 or type 2 are experiencing their diabetes care. Now, do you want to look at this differently? It's a very powerful advocacy tool, and that's where you start. And once governments start to see real data, this is not somebody saying, this is how I feel. They've actually collected data to say, these are the things that matter to people with diabetes, and that's how I'm experiencing my care. It matters to politicians. It also matters to governments, because they're made up of politicians, right? And this is a very political issue. So healthcare, universal healthcare, is always political. Every country I've been in, 40 countries and counting, it's always been political. So use it as a tool to actually do it yourself first, because governments don't have the data, particularly in countries like India, Pakistan, Bangladesh, Sri Lanka, all the countries I've been to. I can't hear you. Yeah, no.
Assalamualaikum. It was very enlightening to listen to you, Nidhi, and I also want to share another aspect of bonding with you. That I started first time pediatric endocrinology clinic was started in Rawalpindi in the most slum or internal city area, district headquarters hospital. It is situated just next to Plaza Bazaar. So since 2014, I started pediatric endocrinology clinic here, and now over 300 patients are having registered with me. And since Dr. Sana contacted me and Meethi Zindagi came, I felt a drastic difference in accessibility to medicine and also in the diabetes education. Previously, what we were doing, sitting at a very congested tertiary care hospital with limited resources, the biggest problem and concern of patients as well as doctor was insulin kahan se aayegi, strips kahan se aayegi. And while listening to this discussion about PROM and universal health care, I just remembered an incident that one of my patients' mother always came, and she never had money even to come to the hospital and go back. And at that time, Meethi Zindagi wasn't there, or we were not aware of Meethi Zindagi. So what we used to do, we had a collection in the ward fund, and we used to help the patient out. Not only by giving insulin by our own pocket, it was not available in the hospital, but also giving them kiraya aane jaane ka. And then one day she came, her husband was unemployed, and she was pregnant. And I asked her, you already have 4 kids, why you can't afford medicine? She said that I only have one male child, and he is also diabetic. So उसने उसकी तरफ से तो उसका ख्याल था कि इसकी तो लाइफ इसका होना ना होना इससे तो ठीक होना नहीं है. So I need another male child. तो यहाँ पाकिस्तान में प्रैक्टिस करते हुए हमारे जो concerns जो हम देख रहे होते हैं, scenario is very different, and the only patient related outcome वही है जैसे उनको इंसुलिन मिल गई है और इस पे वो खुश हो गए हैं. तो ये एक हमारी बहुत बड़ी अचीवमेंट है. But now things are gradually changing and improving a lot.
पेशेंट्स की एक्सेसिबिलिटी इंसुलिन की बेहतर हो गई है, काउंसलिंग की काफी एजुकेशन कुछ हमारा सेटअप है, 2-3 हॉस्पिटल्स में हम पीडियाट्रिक एंडोक्राइन के लिए कर रहे हैं, हमारे पोस्ट ग्रेजुएट ट्रेनीज दे आर गेटिंग दिस ट्रेनिंग and they are also involved in patient care counseling. तो हमारा थोड़ा सा burden share और हमारी next priority I think should be this measurement of we still have a long way to go, but today's talk has given me a way forward कि अब आगे इंशाल्लाह हमने next हमारा क्या plan है, हमने as pediatric endocrinology का नया setup जो हमने scratch से एक city में शुरू किया for the first time, but we are looking forward to achieve. Thank you very much.
बिल्कुल सही कहा आपने, बिल्कुल सही कहा। Somebody else wants to speak? Sana, or do you want me to respond to that?
Yeah, Asad, when he introduced himself. I just wanted to make sure that you are comfortable with whatever you say.
Thank you, everyone. My name is Asad, and I'm diabetic. My question is, so you talked about from and different aspects of it which are related to government, but we understand governments are inefficient. So as type 1 diabetic, what components of PROM I can use so that I am very meticulous about how I capture it. So despite being financially very blessed and looking at things in a very different perspective, but at the end of the day, I'm looking at HbA1c and looking at my regular readings, because I thought we usually have a conversation with my friends and family and partner about type 1 diabetes. But the way you are showing things, I really want you to tell us, because we can't change government, we have Dr. Sana there to advocate on our behalf, but as a starting point, I want to know what I can take away from this and how do I see my blood sugar or my emotions up and downs using this chart.
What a great question. It's a lovely question. Sorry, I didn't catch your name. Sana, what was the name of the gentleman? Can't hear you. Can't hear you. Sorry, I can't hear the room. Could you unmute the room, please, organizers, so I can't hear the room? Okay. Okay. What a great question from the young gentleman. Amazing question. How can you use it? So there are lots of different ways of you figuring out. So I think your name was Arsalan. Is that right? Did I hear the name right? Again, you're muted, so I can't hear you. Yeah. So I think how you can use it is, I don't know whether you carry out a diabetes distress score on yourself. I certainly know that a lot of youth advocates that Sana and I work with, who she knows quite well, including my son, who will use a diabetes distress score. You actually do it yourself to see how you're feeling about your diabetes. And then you can correlate that to some of your biometric measurements, your blood sugars, your HbA1c, or how you're feeling that day. And I would take that diabetes distress score or your PAID score or your PHQ-9 to your provider and say to them, this is what I'm feeling like. Can you look at this and compare this to, because your doctors in the private sector, forget the government. And I totally take your point. We're in a country where universal healthcare is very far off from being achieved. Many countries in Southeast Asia, by the way. Even in countries like Thailand, where they've had UHC for a while, it's very far from being achieved in terms of what is covered. So you take that to your provider and you say to them, and your provider is lecturing you on your blood sugar not being great, is lecturing you on your, why haven't you achieved this? And look at your sugars, they're not great. It's not the way to handle it. Then you've come up with your score and say, this is how I'm feeling about this. Do you really expect me to achieve a great blood sugar when I'm feeling like this? And I can remember one story in which I took my son. At that time, pumps were about to start. He was 7 years old, and we took him, 7, 8 years old. We took him to a really famous doctor. I'm not going to call his name out. In the US, we took him to be to look at to see what was next for us. And that doctor just lectured him for about an hour. And Javier said, I don't care how good his treatment is. I don't care how he's, how good his patient's HbA1c is. I'm never going back to that man because he made me feel like nonsense. So I'm never going to won't use bad words, but that's what he felt like. We never went back to that doctor ever again. Javier was no way he was going to take his advice because of the way he made him feel. So I think rating your own providers, benchmarking your own providers, and how you're feeling about your illness is a really important way to start. I haven't answered your full question, but I'd love to have a dialogue in the future about this with you.
Thank you so much, Nidhi. There's one last question that we're going to take. We've already kept Nidhi over time, and I'm sure she has a lot of commitments at the start of the day. So I'll just take one last question for Nidhi, and then we can move on to the panel discussion. Thank you, Nidhi, so much for today's talk, and this is the last question for you. Thank you so much for this everything talk. And I'm Dr. Faisal Khan, and I'm program manager for the Diabetes program, that is Dietary Nutrition and Diabetes Together. That's an NHR funded program. It's not a question, it's just a comment. I just wanted to apprise your program and the audience that regarding the outcomes, our research group, that is Impact, an NHR funded program, including mental and physical health together. It has a lot of studies that are contributing towards the different interventions related to depression and diabetes and other mental and physical health together. And diabetes is one of the primary non-communicable diseases that we are addressing. So our Impact group has conducted a study, Cosmos, in which we have identified the core outcomes of mental and physical health together, and diabetes is one of the most important. And these outcomes have been identified by the diabetic patients, persons living with diabetes themselves, from at least 10 low middle income countries, and a number of Pakistani persons living with depression and their carers, along with the healthcare providers and policymakers. They contributed to that verify. And so we have some outcomes which have been identified by our crucial stakeholders themselves, and it is under publication. And we will inshallah share the link once the paper is published, and that will be definitely equally beneficial. Thank you.
I'd love to see that paper when it's published, Doctor. Please do share it.
Thank you.
Can't hear Sana.
It was a new thing for most of us. And thank you so much, Dr. Faisal, for talking about diet. I've been part of the study, and I can see that it is going to change quite a few things. The study, all of you might have noticed, Dr. Faiza said diabetic patients, and then she corrected herself and said people with diabetes. Today, we are going to get you all your support on which is our language matters charter. Meeting Zindagi is advocating for using the right language for people with diabetes, because what I believe is what Meeting has just said about advocating for people with diabetes has to begin with recognizing them as experts on their condition. It cannot happen without that. So no more patients, no more diabetics, people with diabetes, experts with diabetes, and that's what we are. There are around 30-35 type 1s here in the audience right now, and I want you all to just give them a big round of applause.
Thank you so much.
I look forward to seeing you in probably ways.
Me too. Have a lovely rest of the conference. Wish you well. Khuda Hafiz, and I hope to see you in person sometime. Thank you so much.
Thank you so much for healthcare ratio. So we have one doctor over 1,300 patients, and that's a very low number. Type 1 diabetes itself needs a lot of time and focus to educate the person living their life in a better and healthy manner. And all those resources that are internationally available, those resources have some cultural and language barriers, so people could not follow that or could not connect with it. So for these many problems, we have one solution, and we are presenting T1D Bits, Pakistan's first ever web platform that is that is going to cater people with type 1 diabetes. And the best part of this resource is that it has been co-created by HCPs and people with type 1 diabetes. So you could actually connect with this resource. And those who can have access to mobiles and laptop, they can easily access it anytime right from their mobile. However, if you do not have the access to the internet, we are also developing 20 centers across Pakistan. So वो तमाम लोग जिनके पास इंटरनेट या मोबाइल या लैपटॉप की फैसिलिटी नहीं है, they can still get educated, they can still get benefit from this resource. And as you can see, we have already signed up with 11 institutes across Pakistan, and we are trying to make it available for all the geographical locations of Pakistan, so everybody, regardless of their socio-economic structure, can get benefit of it. So what's the call to action? We want you to visit the website, explore it. And those who cannot access the website, they can visit their nearest center to get benefit from that, and also spread awareness so those who ever need, so all of those who cannot access or who do not know or are not aware about this resource can start utilizing it as soon as they get it, because it is a need of every type 1 diabetes and their families. I would like to especially thank Rawalpindi Medical University, especially the VC Dr. Mohammad Umar and Dr. Hina Sattar for their foresightedness and coming forward to join hands with this great project. And my whole T1D Bits team, who have played a pivotal role in making this amazing educational resource available for the type 1 diabetes community of Pakistan. So a big round of applause for them. Thank you, Anna, for your dedication to advancing diabetes education. We believe that this platform has potential to make a significant impact on people's lives, and as well as reducing the load on healthcare professionals with creativity resources. So now moving forward, let's share our personal story that resonates with many of you.
नहीं शो
Okay, so we will watch that video later. So there's just a little change to the agenda. So I invite CEO, PC Zindagi, Dr. Sana Ajmal, to please take the lead for panel discussion.
So there is a last minute change, so Fawaz Khan had to join us slightly for a conversation with him, which had to happen live. But due to some health issues, he would be unable to do so today. So we will go forward with the panel discussion first, and then we'll see if it's prepared microphone. Otherwise, we'll play a video that we sent to us for showing you all. Thank you so much for your patience. मुझे सिर्फ अपनी टीम से request करनी है. There's a lot of disturbance going on while you're communicating with each other. So if you please use the side eyes instead of coming in the center, because sometimes हमारा view block हो रहा है. Thank you for that, and thank you for helping out. Just please use the side eyes and try to forward notes seriously. I would like to invite panelists, Dr. Hina Sattar, pediatric endocrinologist, with Family Hospital, HOD. She is coming all the way to us from Lahore University of Health Sciences. Primary healthcare advocate, primary healthcare physician herself, and she has been advocating for improvement in primary healthcare. Would the VC join us now? I just asked the PM is in a meeting, he will join shortly. Okay. Shajid Ahmed from Code for Pakistan, CEO of Code for Pakistan. Thank you so much for joining us. And again, I can see Anna was very close. So she missed out a very important thing that we have discussed many times. Thank you so much for joining us all the way from Peshawar today. So AIMS last week set up the first digitally equipped diabetes education center in the country. Thank you so much, Sabah, for joining us. That's all we did. So AIMS ने वो initiative लिया by establishing the first center, and I'm sure that it is going to improve the uptake across the country. So do we have any comments? I think we just give one mic, okay? Yeah, one mic, okay? This is a slightly smaller. Okay. So as you might be wondering, हमारे साथ very diverse किस्म की panelists की type of and I'm going to explain why. Because अभी आपने इसे भी सुना है, हम लोग सबसे भी बात कर रहे हैं कि it's very important to diversify the dialogue. Because जब हम लोग focus हो जाते हैं patient के ऊपर, और जब हम focus हो जाते हैं medical care के ऊपर, तो we forget the rest of the life that person has to live anyway. The person is a person outside the clinic. जब वो diagnose होता है, diagnosis के बाद उसकी आगे पूरी life है. अगर वो एक बच्चा है, so that child is going to school. अगर वो एक university age की student है, the person is going to university. If they're working in a office maybe. They're doing their own business maybe. They are a laborer maybe. मतलब हम लोग इस चीज को we have to keep in mind that this person, apart from being patient, they have full life. और उस full life के अंदर बहुत सारे stakeholders, starting from their families, their friends, their teachers, their employers, society around them, रिश्तेदार, लेकिन बहुत सारी बातें एक से सुननी पड़ जाती हैं. The myths in the society, culture in the society, the health providers. The health providers में बहुत सारे, आप कभी GP के पास जा रहे हैं, कभी आप specialist के पास जा रहे हैं. Not everyone has access to a specialist. Not everyone has access to a pediatric endocrinologist. Not everyone has access to an endocrinologist. So we have to make sure that there are these voices around the table that can actually bridge that gap. I'll take a volunteer. Since the VC is not with us, would any person with type 1 diabetes like to join me on stage for direct questions? Asif, please. Thank you so much. Sarah, you want to come over? Please. Okay, so both Asad and Sabah happen to have type 1 diabetes as well. And Asad being from the telecom sector and Sabah looking after a hospital that is again taking care of people with type 1 diabetes, looking after the type 1 programs. I think that's going to be very insightful. Actually, let's start. Let's start with the medical education bit. VC is not here yet, but I would really want to ask you this question, Dr. Hina and Dr. Hina, both Dr. Hina. We often see a lot of missed diagnosis, specifically जब हमारे पब्लिक सेक्टर में या हमारे रिमोट एरियाज में जब हम जाते हैं किसी हेल्थ केयर फैसिलिटी में, there are generally very young graduates who are looking after, very fresh graduates who are looking after these people. And there's a lot of misdiagnosis. Now, Humanity Index is an international forum that puts in data जो भी available होता है, उसके basis पे they put that in that data to showcase a country's situation. Humanity Index ये कहता है कि पाकिस्तान में 46.7% early death है with type 1 diabetes. This is huge. This is a moment of reflection for all of us. Almost one in every 2 people with type 1 diabetes pass away early. We don't know why. It's either because diagnosis was at that time and the child passed away or the adult passed away. Yeah, care properly maybe, and they develop complications and pass away. We don't know in दोनों के दरमियान में difference क्या है, but we do know that there is a 46 to 47% early death rate. What is medical education looks like? जब हम बात करते हैं medical students की, जब उनको पढ़ाया जाता है in medical colleges, how much focus is given on type 1 diabetes at that stage?
Actually, Sana, I have been involved in medical teaching for last about 10 years, and I have also contributed in making curriculum for undergraduate and postgraduate programs at Calcutta Medical University. Till 4th year MBBS pediatrics is considered as a minor subject, and medicine is taught as main subject. In final year, we have good number of lectures and also about 300 teaching hours per year of pediatrics. I think that this problem of delayed diagnosis we will be able to tackle if the student spends more time with real patients in wards. The clinical exposure, the benefit of clinical exposure is much more than the classroom teaching. So I think that I have personally felt that जितना मर्जी क्लासरूम में बैठ के पढ़ा ले, जब तक पेशेंट के साथ एक्सपोजर नहीं होगा, देखेंगे नहीं पेशेंट, तब तक उनको उस तरह से पिक करना नहीं आएगा. So one thing is this. इसको टैकल करने के लिए हमारी रिकमेंडेशन भी होती हैं और हमें प्री क्लिनिकल ईयर्स, सेकेंड ईयर, थर्ड ईयर एमबीबीएस के जो पहले वार्ड से नहीं आते थे, उनमें भी आहिस्ता आहिस्ता वर्टिकल इंटीग्रेशन ला रहे हैं कि क्लिनिकल ईयर्स जो रोटेशन है वो अर्ली स्टार्ट हो जाए फ्रॉम द इनिशियल सेकंड थर्ड ईयर से. और दूसरी बात ये जहाँ पर स्पेशलाइज्ड क्लिनिक्स हैं, जैसे डायबिटीज क्लिनिक हमारा वीकली होता है, उसमें इनके रोटेशंस कंपल्सरी स्टूडेंट्स होनी चाहिए. फाइनल ईयर एमबीबीएस को ब्लॉक फिल करवाते हैं, उसमें एक उनका ये कंपोनेंट भी ऐड कर देना चाहिए कि उन्हें जैसे उनका वैक्सीनेशन सेंटर हुआ है या बहुत सी जगह तो ये सेटअप्स अवेलेबल नहीं होंगे, शायद वहाँ पर ना हो सके. पेंस में है जैसे डॉक्टर रहमाना वाले से डॉक्टर गुरमीत शायद वहाँ स्टार्ट किया था, उसके साथ जो भी रिलेटेड मेडिकल कॉलेज है और रावलपिंडी मेडिकल यूनिवर्सिटी है, ये ऐड करते हैं कि अपनी 1 मंथ या 4 वीक्स की रोटेशन में they are supposed to attend at least one करने के उन्हें things they must attend things I think can improve and no doubt there is a gap. और इसी वजह से हमारी जो स्टडीज होती है, जितनी यहाँ पर पाकिस्तान का डाटा है, उसमें जो इनिशियल मोड ऑफ प्रेजेंटेशन है ना टाइप 1 डायबिटीज का, दैट इज डायबिटीज कीटोएसिडोसिस. और उसकी शायद बाकी दुनिया में भी फर्स्ट प्रेजेंटेशन का मोस्ट कॉमन मोड डिके ही हो, लेकिन इंसिडेंस इज वेरी हाई इन पाकिस्तान. इसलिए क्योंकि पहले से इनिशियल सॉफ्ट साइंस शुरू होते हैं, कोई डिप्सिया है, कोई यूरिया है, वेट लॉस है, तो नोबडी थिंक्स, क्योंकि जब हम इवन डायग्नोसिस कंफर्म हो जाता है पेरेंट्स को बताते हैं, फर्स्ट रिएक्शन ये होता है कि बच्चों को भी शुगर होती है.
So after going to all the sort of better for the show of your hands, how many of you actually knew about type 1 diabetes and that it can happen in children? Hardly, I think 10%. आप में से कितने लोगों को मीटिंग के साथ एसोसिएट होने के बाद या हेल्थ के प्रोफेशनल्स बनने के बाद बात पता चली? So I'm talking about the general public. How many of you actually knew this before coming in contact with us or coming in contact with medical education that came to know about that?
My first experience is with you. The first time I found out a young person could have it was when I saw you have it. And that was not even general. It was like I think O levels. Not even that.
ये कितना कॉमन कमेंट है जो हमें मिलता है that हमें सबको जानने की वजह से we all know what it is. हम सबको कोविड की अवेयरनेस हो गई बहुत अच्छी because the government took up an initiative to spread that awareness. It can be something as simple as a ringtone on the mobile. It can be something as simple as text messages to every subscriber in the company. It can be something as simple as putting up an ad on the media. There are so many ways to do that. लेकिन सबसे पहला जो मुझे लगता है misdiagnosis का है, correct me if I'm wrong. Do you think that there's a lot of misdiagnosis because families बहुत late लेकर आती हैं बच्चों को in the healthcare setup? Dr. Hinan Javed, if you would like to answer this.
If we go down to the grassroots level, grassroots में basics से start करें, health system के कई tiers होते हैं. The bottom, the basic, जो foundation आपका बना है, वो primary healthcare system. इसमें आप ये अगर पब्लिक सेक्टर में देखें तो BHU RLC आ जाएगा या प्राइवेट सेक्टर में देखें तो जो जनरल प्रैक्टिशनर बैठा हुआ है आप किसी चीज में अर्बन सेक्टर से आ जाएगा. उसके बाद आपका सेकेंडरी केयर, टर्शियरी और फिर स्पेशलाइज्ड यूनिट्स हैं जैसे PKLI, डॉक्टर खान which have got specified mode of action. अब एक कंट्री में जैसे मैंने मीटिंग को भी पहले कहा कि एक कंट्री में से अगर आप पहला टीयर हटा दें प्राइमरी. Can everybody hear me at the back? Yes. Okay. So अगर आप प्राइमरी केयर का टीयर बेस और फाउंडेशन हटा दें और उसके ऊपर बाकी की इमारत खड़ी करें, उसकी पहली मंजिल और दूसरी मंजिल, that is not going to survive. It is a recipe for disaster. बहुत दफा कहा जाता है कि because I have to dialogue at multiple levels and as part of policy making.
I would like to just put in a line because this is streaming live on our social media pages. I don't think it's working. It's not working. Is it? Right? Okay. So
The thing is, there's not working, and there has been, इसमें multiple issues आ जाते हैं. And as I said, we don't know where the starting point is, so you have to start from somewhere. You have to cover the entire ground. It's a national level. ऐसा नहीं है कि सिर्फ एक ही part of the country में primary care exist नहीं करती. Now, what does a primary care physician does? They sit in the community outside the hospital. वो एक society के अंदर बैठ रहे हैं and they provide holistic care. सिर्फ उनका काम prescription लिखना नहीं है, दवाई लिखना नहीं है. Holistic care का मतलब ये है कि बायो साइको सोशल एस्पेक्ट, जैसे कोई भी क्रॉनिक डिजीज होती है, क्रॉनिक डिजीज का मतलब जो 6 महीने से ज्यादा रहे, डायबिटीज इज वन ऑफ देम. उनसे जो लोग आते हैं उनको मेंटल हेल्थ प्रॉब्लम्स जैसे लो मूड, डिप्रेशन, एंजाइटी कॉमन होता है. नॉर्मल पॉपुलेशन में भी होता है, लेकिन अगर आपको एक डिजीज है पर्टिकुलरली यंग एज में तो ये एस्पेक्ट ऑफ लाइफ भी आपको असेस करना पड़ता है. नाउ व्हेन दैट डॉक्टर इज मिसिंग फ्रॉम दैट सोसाइटी, तो वो आइडेंटिफिकेशन ऑफ अ न्यू सिम्टम इमर्जिंग बिकॉज समथिंग अदर देन द डिजीज या पेशेंट एजुकेशन. मरीज को देखिए प्रॉब्लम कहाँ पे आपको आता है, जब आपको बीमारी का पता नहीं होता. बहुत से एडल्ट टाइप 2 डायबिटिक्स भी आते हैं और कई दफा वो इस तरह की बात करते हैं, मैं फलाने हकीम के पास गई थी और उन्होंने कहा था 1 खजूर या 2 खजूर रोज खा लो तो शुगर सही रहेगा. Now, when an educated community comes and says that, the first thing that matters is क्या इनको अपनी बीमारी के बारे में पता है, समझ है कि नहीं. So first point is understanding. अब understanding कौन देगा आपको? Specialist के पास इतना टाइम नहीं, right? वो एक जब disease advance या एक stage पे उसके बाद take over करते हैं. So primary care physician एक ट्रेन जीडी लफ्ज ट्रेन के ऊपर फोकस है। पाकिस्तान में अनफॉर्चुनेटली इस वक्त जो जीडीज हैं वो अनट्रेंड हैं, मेजॉरिटी अनट्रेंड हैं, और पब्लिक सेक्टर के अंदर जनरल प्रैक्टिस या फैमिली मेडिसिन या प्राइमरी केयर फिजिशियन की कोई पोस्ट ऑफ केडर नहीं है। Pakistan has got one of the largest setup of more than 5,000 PHUs and RHCs across the country. और वो 5,000 का रिसोर्स आपका इस वक्त वेस्ट हो रहा है क्योंकि वहाँ पे बैठने वाला ट्रेन डॉक्टर नहीं। That's the bottom line.
So, Dr. Sanam, Marina, in this group, just an added on this. What do you think is the gap? What do you think is the gap in that training? What is the challenge that either the government or the primary care physicians face? जिस वजह से gap exist करता है जहाँ पर training
Right. देखिए प्राइमरी केयर किसी भी कंट्री का आप देखें, it needs the will of the government. The will of the government needs to exist for primary care to be established. आप कोई भी कंट्री उठा लें, वहाँ पे गवर्नमेंट की सपोर्ट आएगी, चाहे वो ईरान हो, चाहे टर्की हो, चाहे कंट्री लाइक क्यूबा हो, वेस्ट की बहुत सी पॉपुलेशन है ये। सो वो एक ओनरशिप, एक रिकग्निशन, एक एक्नॉलेजमेंट आनी चाहिए। इट्स एविडेंस बेस्ड, इसमें कोई दो रानी नहीं है। We have been lots of platforms, multiple stakeholders जहाँ पे हम evidences लेकर गए हैं और दिखाया है। इस तरह में बात करने की हद तक नहीं है, it has been proven. Burden of disease पाकिस्तान में बहुत सी conditions का हाई है, diabetes is one of them. लेकिन अगर आप infectious diseases पे आ जाएं, जैसे HIV है पाकिस्तान में बहुत तेजी से rise कर रहा है और उसकी cause preventable cause है इस्तेमालशुदा सुई का दोबारा इस्तेमाल। We know it, but we don't want to do anything about it. Similarly, hepatitis C और B भी बढ़ रहा है पाकिस्तान इस्तेमालशुदा सुई है। So it's a vicious circle we are going in. कुछ empathy भी हमें चाहिए। We get a lot of donations. Universal health coverage की बात आई, but that project is on hold for a good few months because of change of government and stuff. So we are hoping कि equitable health अगर आपने provide करनी है, across the board provide करनी है, without any discrimination provide करनी है. It's not just for diabetes, for anything under the sun. You need to have a proper system in place. Otherwise, हम ये बातें करते जाएंगे. We'll just go around in circles, and there is no end to it.
Thank you so much for this. Yes,
I'm not a medical practitioner. मैं डॉक्टर तो नहीं हूँ, बट मेरे ध्यान में एक आइडिया या Yeah. Don't find a purpose. And we have another example of somebody from us who worked since super senior sort of people, they can be part of this, and then they have a hierarchy of sort, like your president and the vice president and those sort of hierarchies. I think it's going to have a minimal role, but role nonetheless in this category.
For the suggestion, and yes, we're working on that, but again, इतना बड़ा load है, मेरी जिंदगी के लिए कुछ भी नहीं कर सकते, and that is why it's important for all stakeholders to join hands and for us to innovate how to make the human resource burden as well as the financial burden as minimal as possible while being able to use the outcomes. I'm sorry, there's some issue with Thank you so much. Finally, thank you. So my next question, Sabha, if I can touch you here. पेशावर जैसे एरिया में बैठे हुए जहाँ पर बहुत सारे कल्चरल बैरियर्स हैं, स्टिग्मा भी बीच में मौजूद है, and diversity the level from our original questions right now, because I think we have two people who are not exactly from the regular field, but touched by diabetes themselves and running a system which takes care of diabetes. What is the biggest barrier that you face about with people जो कि कंजर्वेटिव माहौल से आए हैं, जहाँ पे शायद टाइप 1 डायबिटीज एक काला दाग है उनकी एक्सरसाइज के नाम?
Thank you so much, Sana, for inviting me here today. Lovely audience, lovely gathering. यहाँ पे बात हो रही है स्टिग्मास की और सना का बड़ा इम्पोर्टेंट सवाल है कि स्टिग्मा क्या है। तो मैं आपको अपनी छोटी सी स्टोरी सुना देती हूँ क्योंकि from Peshawar, I belong from Peshawar. I was 5 years old when I was diagnosed with type 1 diabetes. And back then type 1 diabetes का तो क्या, diabetes का तो कोई सवाल ही नहीं था कि जैसे कि अभी भी पहले बात हो रही थी कि बच्चों में type 1 diabetes, even doctors were shocked when I went to Aga Khan Hospital, Karachi. And उसके बाद मेरी journey start हुई, did my MBA, went to bank, I'm a banker actually, and then did my healthcare professional degree, and now I'm running a hospital और diabetes center के नाम से, sugar hospital के नाम से पेशावर में, और हम community में काम कर रहे हैं। Basically मेरा काम जो है ज़्यादातर community में ही है और मैं स्टिग्मा को रोजाना डील कर रही हूँ। स्टिग्मा नंबर 1, इसकी शादी नहीं होगी, इसके बच्चे नहीं होंगे। स्टिग्मा नंबर 2, इसके बच्चे नहीं होंगे और इसकी ज़िंदगी ख़त्म हो गई है, इंसुलिन की इंजेक्शन रह गई है इसकी ज़िंदगी। एंड बेसिकली द पेशेंट हिम और हरसेल्फ इज नॉट सेइंग दैट, क्योंकि वो बच्चा है, वो तो कंफ्यूज्ड है। द पेरेंट्स एंड द पीपल आर सराउंडिंग दैट पेशेंट, दैट चाइल्ड। आई एम सॉरी टू यूज द वर्ड पेशेंट, आई एम अ हॉस्पिटल एडमिनिस्ट्रेटर, तो अगर मेरे मुंह से पेशेंट निकल गया सर, आई एम सॉरी फॉर दैट। तो द थिंग इज कि बच्चा जो है वो इस टर्मिनोलॉजी से खबर नहीं है कि मेरे साथ हो क्या रहा है, या मेरी शादी होगी कि नहीं। अगर एक 10 साल बच्चे को आप कहें कि तुम बड़े हो जाओगे और तुम्हारी शादी नहीं होगी, तुम्हारे बच्चे नहीं होंगे, तो उसकी जिंदगी पे ज्यादा फर्क उस टाइम पे नहीं पड़ना, क्योंकि उससे तो यही सोचना है कि मैंने घर जाके अपना होमवर्क करना है और मैंने खेलना है। प्रॉब्लम हमारी कम्युनिटी को ज्यादा है, पेरेंट्स को ज्यादा है। यहाँ पे काफी ज्यादा पेरेंट्स बैठे हुए हैं बच्चों के साथ, और हमारे सराउंडिंग रिश्तेदारों को ज्यादा प्रॉब्लम होती है हमारे टाइप 1 डायबिटीज के साथ। मेरे साथ भी सारी जिंदगी यही मसला है। I got married, alhamdulillah, I'm a mother of 4 children right now, and I'm running a hospital for diabetes. And I think I broke all those stigmas and barriers जो कि पेशावर जैसी जगह पे काफी ज्यादा आए हैं। हम लोग कम्युनिटी में जब जाते हैं बच्चों के स्कूलों में, तो हम सबसे पहले बात टीचर्स के साथ और पेरेंट्स के साथ यही करते हैं कि काइंडली इनको एक नॉर्मल बच्चे की तरह ही ट्रीट करें, जो कि सिर्फ अपना पढ़ाई करना चाहता है, अपने कुरान शरीफ की कायदा पढ़ना चाहता है और अपने प्लेग्राउंड में खेलना चाहता है। उसको ये नहीं पता कि मैं बड़े होकर शादी करूंगा या बच्चे लाऊंगा, उससे सिर्फ ये 3 काम करते हैं। सो लेट देम एंजॉय, सबसे पहले तो हमारा ये काम है। और स्टिग्मा ब्रेक करने के लिए भी मेरे ख्याल में नॉर्मलाइजेशन, जैसे कि मीठी बोल और टिडबिट्स जैसे प्लेटफॉर्म्स, I think it's a commendable job, and I would really commend Anam and Sana for doing it. And I would also endorse Assad's remarks कि अब हमें गवर्नमेंट के पास जाकर रोने धोने से कुछ नहीं मिलने वाला, वो काफी अरसे से मैं कर रही हूँ। लेकिन अगर हम अपने लेवल पे, जैसे कि इतने अमेजिंग डॉक्टर्स मेरे साथ यहाँ पे बैठे, अमेजिंग डॉक्टर है ना, काम सुंदर बेस्ड, लेकिन अगर हम लोग अपने लेवल पे, यूनिवर्सिटी लेवल पे, मीडिया हमारे साथ आज बैठी हुई है, Sundar did a great job. तो अगर ऐसे मीडिया के लोग और जैसे कि अभी आज की ऑडियंस बैठी है, सिर्फ अगर हम लोग भी जो पेरेंट्स बैठे हैं, सिर्फ हम लोग भी नॉर्मलाइजेशन अपनी कम्युनिटी में ले आए, इर्द गिर्द की कम्युनिटी में, कि बच्चा जो है उसने ये नहीं सोचना कि उसने क्या करना है आगे 20 साल के बाद, उसने अभी जो करना है वो उसके लिए बहुत नॉर्मल है और बच्चा बिल्कुल नॉर्मल है। वो पढ़ भी सकता है, वो लिख भी सकता है, वो बोल भी सकता है और वो एक स्कूल के जनरेशन के साथ सब कुछ कर सकता है। अनफॉर्चुनेटली पाकिस्तान में ये काम करना जरा मुश्किल है और काफी रिश्तेदारों और आंटियों को काफी मसले हैं, लेकिन इन आंटियों के साथ मिलकर भी हम ये काम कर सकते हैं क्योंकि डायबिटीज हर एक घर में मौजूद है। So this is all I can say, sir. But change diet. डॉक्टर साना जो कुछ कर रही है मेरे ख्याल में चेंज वो काफी दूर नहीं है कि हम लोग भी जो है डायबिटिक पेशेंट से, पीपल लिविंग विद डायबिटीज से नॉर्मल लोगों को कहना नॉर्मल शुरू कर देंगे इंशाल्लाह।
मैं जैसे एक कमेंट करना चाहूँगी, असद ने भी बात की, सभा ने भी कुछ सिमिलर बात की कि देखें हेल्थ एंड एजुकेशन दो चीज़ें हैं जो गवर्नमेंट की रिस्पॉन्सिबिलिटी होती है। You cannot let them off the hook for these two things. As citizen of this country, ये आपका right है कि आप ये दो चीजें, it's every government's job. They know it, so it's your right to ask. You shouldn't just give away your right like that.
I would not let anyone off the hook. You are sitting in Mobilent, right?
No.
There are so many other tech companies here. I specifically made sure that we have tech companies representatives here because it's all our jobs. As Pakistani individuals and organizations, we know we have a crumbling healthcare system, we have a dysfunctional government, but having said that, there's so many things that happen. And so many of us can do so many things with simple solutions, low-cost solutions. Till the time we can actually shake the government's legs, push the goal. Because every day there are kids dying. 2 months pehle, the government wrapped up its insulin support program, जो already बहुत सारी जगहों पे बिल्कुल negative था. It was irregular. It had a lack of capacity. Even that was wrapped up because of the economic crisis. 7 children passed away on my waiting list. That burden resides on my head. Every night I sleep. वो 7 बच्चे जो मरे मेरी waiting list पर, मुझे उनका दुख ही और पता नहीं कितने ऐसे मरे हैं जिन्हें हमें पता ही नहीं, उनको शायद कभी पता ही नहीं चला कि क्या भी हमारा ऑप्शन है। So we have to stand together. We as a nation have to stand together, and yes, we as organizations have to stand together and again keep raising more noise for the government to play its role. I'll come to Shaji. Shaji, thank you so much for joining us today. You might have been a little unsure before coming, but I'm hopeful that after going back, you will be more sure of what your role can be in this. So, Code for Pakistan has been doing some work for cancer. एक चीज जो हम and they did a lot of work in COVID and as well as in floods. एक चीज जो हमें नहीं पता इस टाइम पे पाकिस्तान में, we don't know कि कहाँ पर कितनी need exist करती है और क्या need exist करती है. Specifically coming to type 1 diabetes, we do not know कि किस area में कितने बच्चे हैं. So floods happened and I start the question with a story. Floods happened, all of a sudden floods आ गए. Number 1 तो उसकी कोई forward warning नहीं. Except for the children who were being supported by us, we did not know किस कैंप में कितने बच्चे या किस एरिया में कितने बच्चे या adults they require insulin. We started our flood relief operation. हमने बहुत जल्दी उसको सारा setup किया. We started sending out supplies. But our team had to go from house to house to check कि क्या इस घर में type 1 तो नहीं. हमारी टीम को literally boat spectrum एरिया तक पहुंचना पड़ा. इस एरिया में हम लोग को बच्चा ऐसा तो नहीं जिसको इंसुलिन की जरूरत है और वो उसको इंसुलिन नहीं मिल पा रही उसकी. We had to go from camp to camp. But what they did in COVID, and I was very impressed by that during COVID as well as during floods, was a hotspot system, and I like Shaji speak to it. कि किस तरीके से उस चीज ने help out किया in ensuring a response to the challenges that were being faced.
Thank you. Pakistan is a non-profit civic tech organization. We have governments build systems for us. तो जब लोग बात करते हैं कि गवर्नमेंट काम नहीं करती है, और गवर्नमेंट हमारे लिए कुछ नहीं करती है। आई फील इट वेरी क्लोजली बिकॉज आई वर्क विद दोस पीपल एवरी डे एंड आई सी कि वहाँ पे उन लोगों को किन मसाइल का शिकार होना पड़ता है। दे आर पीपल लाइक अस और उनको किन मसाइल की कमी है जिसकी बुनियाद पर वो तमाम ये काम नहीं कर पाते जो कि आप चाहते हैं। आई स्टार्ट विद कोविड क्योंकि कोविड वाज द फर्स्ट थिंग दैट हैपेंड। जब कोविड आया था तो वी वर द फर्स्ट पीपल टू बी कॉल्ड टू डेवलप एटलीस्ट हेल्प आउट विद द डेटा जो कि कोविड के ज़माने में करेक्ट करना था कि जिसकी बुनियाद पे हमने कोविड से अच्छी तरह लड़े हैं। हम लोगों ने तकरीबन एक हफ्ता मिनिस्ट्री में गुजारा टू सेट अप अ डेटा पाइपलाइन टू इंश्योर कि आपके अस्पतालों में जहाँ भी कोविड रिपोर्ट होता है वो इमीडिएटली एक दिन के नोटिस के अंदर वो आपको सेंट्रल किसी रिपोजिटरी में पहुँचे ताकि आपके जो डैशबोर्ड से कोविड के तमाम डेली बेसिस पे पॉपुलेट हो सके। इसमें बहुत सारा किरदार जो था वो फौज का था क्योंकि they were the ones who were controlling it, they were the ones who were making sure कि वो डेटा अस्पताल से कलेक्ट हो, they were the ones making sure कि वो डेटा एंटर हो सिस्टम में and they were diligently keeping tabs on everything that was happening। ये diligence आपको नॉर्मल हॉस्पिटल प्रोसीजर में नहीं नजर आ रही है। I'm sorry to say, हमने बहुत जगह देखा है कि आप लोग अभी हम लोग वर्किंग विद KDH राइट नाउ, कैंसर वार्ड है, दे आर कलेक्टिंग एक खातून है वहाँ पे, शी इज हेड ऑफ डिपार्टमेंट, ऑल कैंसर डेटा इज राइट नाउ इन हर लैपटॉप। उस लैपटॉप की जितनी हिफाजत की जाती है वहाँ पे वो देख के हमें परेशानी होती है। अगर ये लैपटॉप को कुछ हो गया, पिछले 5-10 साल का कैंसर का हर पेशेंट का डेटा उन्होंने संभाल के रखा है, वो ज़ाहिर हो जाएगा। कोविड में ऐसा नहीं हुआ। उसकी वजह ये थी कि हमने गवर्नमेंट ने उस वक्त फैसला किया था कि उन्होंने ये डेटा मैनेज करना है, ये डेटा स्टोर करना है। उसके ऊपर चूंकि पेंडेमिक था और दे वर अंडर प्रेशर, दे वर फोर्स्ड टू डू अ लॉट ऑफ दीस थिंग्स। वो एक कहानी है कि अगर आपके पास ऐसी सिचुएशन बनती है कि जब आपके पास पेंडेमिक है तो वी डू एक्चुअली कलेक्ट डेटा एंड वी डू दैट।
I would like to respond to it by saying that they were forced to act. Now the health indicators जो पाकिस्तान के इस वक्त speaking volumes globally, we are leading in hepatitis C in the world. हम number 1 पे आ रहे हैं hepatitis C. So I think government should now feel the pressure.
I'll come to that. I'll come to the other part. मेरा फिर आप लोगों से सवाल ये होता है कि अगर गवर्नमेंट नहीं कर रही है, what are we doing to collect our own data, right? हम लोग I think हम में से तमाम लोगों के पास जहाँ मोबाइल फोन है, we all have access to it. We all have access to the computing technology that is needed to collect and store data for, I think, I don't know, पिछले 10 साल का डेटा आपके पास या होता अगर आप लोग शुरू से उस डेटा को कलेक्ट कर रहे होते हैं, डॉक्टर्स would have access to that data to decide किसके साथ क्या करना चाहिए। हम लोग नहीं करेंगे, ठीक है? इसमें गवर्नमेंट कुछ नहीं कर सकती। अगर हम चाहें तो हम खुद ये डेटा इकट्ठा कर सकते हैं और हम खुद उस डेटा को इस्तेमाल कर सकते हैं, लेकिन हम नहीं करते। इसकी मिसाल कोविड के बाद जब फ्लड्स हुए थे, फ्लड्स के अंदर भी हमने यही नोट किया कि गवर्नमेंट ये डेटा नहीं कलेक्ट कर रही है, गवर्नमेंट इज नॉट नो कि कहाँ क्या होता है। फ्लड्स में हमने 2 अप्रोचेज की थी। एक तो क्राउडसोर्सिंग की अप्रोच थी कि लोगों को कहा कि भाई आपके पास अगर इंटरनेट है, आपके पास एक प्लेटफॉर्म हमने बना दिया है, इसके अंदर आप डेटा रिपोर्ट करें। सो दिस वाज सेल्फ रिपोर्टिंग व्हिच वाज सेइंग कि आई नीड हेल्प, आई नीड फूड इन दिस लोकेशन, आई नीड मेडिसिन इन दिस लोकेशन, आई नीड टेंट्स इन दिस लोकेशन। और वो डेटा, वो प्लेटफॉर्म हमने खोला लोगों को एंड वी पब्लिसाइज द डेटा। A number of civil society organizations like Al-Khidmat, they took upon themselves to use that platform to coordinate all of their efforts in times of flood, to make sure कि जहाँ जहाँ कोई केस इमर्ज होता था, रिपोर्ट होता था, उसको वो जाके इंडिविजुअली हैंडल करती थी। हमारी टीम उस डेटा की वेरासिटी पे चेक कर रही थी कि वो डेटा जो आ रहा है, जो रिक्वेस्ट आ रही है, वो सही है कि नहीं है, वो गलत है कि नहीं है। उसको कॉल करके हाई से पूछते थे कि क्या आपकी बाकी की ज़रूरत है कि नहीं है। And we made sure that something happened with every data point. either it got resolved or it got closed or something, ताकि लोगों को ये ना हो कि हमें इनके प्लेटफॉर्म से इमदाद नहीं मिली. But that took a lot of diligence and effort on our part and on part of the local governments. जिनके असिस्टेंट कमिश्नर और डिप्टी कमिश्नर ने गांव-गांव जाके वेरीफाई करके दिया कि हाँ ये बात सही कर रहे हैं, यहाँ पे 50 लोग बैठे हैं, यहाँ पे 100 लोग बैठे हैं.
Yeah, I would like to address this. Individual efforts exist कर रहे हैं. Pakistan is a country जहाँ पे philanthropy बहुत है. We are relying on the goodness of the heart. So hats off to this resilient nation. लेकिन अगर आपको larger उसमें aspect को cover करना है, and you want to, because currently PNNCH WHO की एक सब division है, उसने 10 countries पहले select की थी, अब 5 countries हैं. Pakistan is not one of them. And the investor जो कि Harvard से belong करते हैं, Bill and Melinda Gates Foundation and huge donor agencies, they will not invest in Pakistan because Pakistan की तरफ से advocacy नहीं हुई है. वो advocacy individual नहीं कर सकता है, वो government को इफेक्ट होती है, because government has the machinery, government has the human resource, government has all kind of resource under the sun and the data. जहाँ पे government ने act करना होता है, वो outstanding काम produce करती है, जैसे आपने COVID में कहा. So why can't that same infrastructure in every way or form be applied for rest of the medical conditions?
So actually we are not used to collect the data. आप कहीं पे register रख लेना, आपका ना पीजी करेगा, ना एचओ करेगा, ना डॉक्टर करेगा. जब आप डाटा नहीं देंगे गवर्नमेंट को, तो गवर्नमेंट एक्शन कहाँ से लेगी? That is the point. उसको मैंडेट किया जा सकता है. आप उसको नहीं मैडम, ये हमारे एंड पे गलती है. आप अनफोर्स नहीं करते अपने जो. अगर आप
I would just like to, with your permission, I would just like to finish off this comment. अगर आप promotions गवर्नमेंट के अंदर promotions के साथ ECR reports के साथ लगा दें, mandatory requirement, everything can happen. You have to get accountability, you have to get whistleblowing policy and the harassment policy in place in order to do the job.
So Shaji, I have a question. Can we do something similar for diabetes?
मैं exactly उसी तरह बात है. उन्होंने point out किया कि we're not collecting data. मेरा सवाल ये है कि RMC जैसे institute है, right? IMU के पास डायबिटीज का डेटा आता है, हमारे अस्पतालों में डायबिटीज का डेटा आता है. क्या वो फाइलों से बाहर निकल के किसी कंप्यूटर में या किसी सर्वर पे जा सकता है कि किसी को गवर्नमेंट इस्तेमाल करे? आपने assumption की थी कि गवर्नमेंट के पास डेटा है. गवर्नमेंट के पास एक्चुअली डेटा नहीं है. गवर्नमेंट के पास वो डेटा होता है जो यूनिवर्सिटी उन्हें प्रोवाइड करती है. गवर्नमेंट के पास वो डेटा होता है जो उन्हें रिसर्च इंस्टीट्यूट या मेडिकल इंस्टीट्यूट अस्पतालों से निकल के. हमारे अस्पतालों में पेशेंट की फाइलें जो हैं वो तो कागज में, उसके ऊपर जो डेटा बन रहा है वो डॉक्टर्स या एडमिनिस्ट्रेटर्स जो हैं वो उन फाइलों में से गुजर के एट द एंड ऑफ द मंथ और एट द एंड ऑफ द ईयर वो डेटा कंपाइल करके हुकूमत को देते हैं कि हमारे हिसाब से जो हमने मैनुअल लेबर किया है उसके हिसाब से इस वक्त मुल्क की ये सिचुएशन है. वो डेटा कितना एक्यूरेट है, कितना कॉम्प्रिहेंसिव है, वी डोंट नो. और हमारा सबसे बड़ा
solution from the data. Being running a diabetes hospital since 2015, we have above 3 million data of diabetes. KP में जितने भी इलाके हैं 10 से हमने पहले collect किए because we are doing community camps. And Shaji, I would correct you on this के data हमारी फाइलों में नहीं, हमारे hospital software में पड़ा हुआ है. And the government is only utilizing that data जो कि उनके प्रोजेक्ट्स के साथ रिलेटेड हैं. जैसे डायगन का प्रोजेक्ट हमारे हॉस्पिटल में अगर चल रहा है और खैबर मेडिकल यूनिवर्सिटी आके वो हमसे कलेक्ट करी है, तो दैट इज गिवन. हम लोग कितनी दफ़ा मिनिस्ट्री गए हैं, कितनी दफ़ा डीजी हेल्थ के पास गए हैं कि वी हैव मिलियंस ऑफ डेटा एंड वी हैव आइडेंटिफाइड द मेन बिग एरियाज अराउंड केपी इनसाइड पेशावर जहाँ पे डायबिटीज की इंसिडेंस बहुत ज़्यादा है. अगर मैं आप लोगों को परसेंटेजेस बता दूं तो वो भी मेरे पास पड़ी हुई है सारी केपी की बेस्ड ऑन माय ओन डेटा. Because the thing is that the government is not interested in that data, I'm sorry to say. DG Health is only interested in the diagram data. Why? Because that is a funded project from NHS London. And the minister is also interested in all the public health projects that's being carried out by Harvard Medical University and the data collected from the Institute Hospital. So the thing is कि एक platform होना चाहिए government की तरफ से that we cannot start. We have already our hospital management system started. So अगर government इसमें अपना hospital management system या कोई अपना data collection tool बनाता है specifically diabetes के लिए, then why not? We are already 5 से कब का data हमारा 2015 से hospital management system में बना है.
आपके जो EMR होते हैं इलेक्ट्रॉनिक मेडिकल रिकॉर्ड उसके पब्लिकली ओपनली अवेलेबल सॉफ्टवेयर होते हैं. हमारे यहाँ पब्लिक हॉस्पिटल्स के अंदर उनको रिकमेंड किया जाता है कि उनके पास हार्डवेयर नहीं है और सिस्टम राइट. इट्स अ कैश 22. हमारा मसला ये है कि हमारे पास क्योंकि पैसे नहीं है उन सिस्टम में इन्वेस्ट करने के लिए, क्योंकि उस लेवल पे पहुंचने के लिए जहाँ पे हम डेटा का इस्तेमाल कर सकें, वहाँ तक पहुँचने के लिए आपको इन्वेस्टमेंट चाहिए और ऐसी इन्वेस्टमेंट चाहिए जो कि हम लोकली प्रोवाइड नहीं कर सकते. हम जैसी ऑर्गेनाइजेशन छोटे लेवल पे तो करती हैं. मिसाल के तौर पे अभी हम पेम्स के साथ एक सॉफ्टवेयर बना रहे हैं व्हिच इज सपोर्टेड बाय वर्ल्ड हेल्थ ऑर्गेनाइजेशन, बट दैट्स फॉर हेल्थ केयर एसोसिएटेड. KTH में जब हम काम कर रहे हैं, दैट्स ऑन ट्राइंग टू फिगर आउट व्हाई डू वी गेट डिफरेंट टाइप्स ऑफ कैंसर. उसमें भी गवर्नमेंट की फंडिंग थोड़ी सी अवेलेबल है, इसलिए कि जो नेशनल सेंटर फॉर बिग डेटा एंड क्लाउड कंप्यूटिंग है, उन्होंने उनकी मदद से एक लैब पेशावर में बनी हुई है, प्रिसीजन मेडिसिन लैब एक रहमान मेडिकल इंस्टीट्यूट के अंदर. दे आर कलेक्टिंग डेटा एंड दे आर पब्लिशिंग दैट डेटा ऑन देयर ओन ताकि लोग उसको इस्तेमाल करें. हमारा जो एक कल्चर जो है यहाँ पे कि हम डेटा कलेक्ट तो कर लेते हैं बट हम उसको पब्लिकली शेयर नहीं करते. If you go to any research institute, any university, I was talking to NED the other day. उनसे मैं कहता हूँ कि आपके जो स्टूडेंट्स जितनी रिसर्च करते हैं, I'm talking about urban research, urban development का डिपार्टमेंट है, जितनी रिसर्च करते हैं वो कहाँ है? तो थीसिस में पड़ी हुई है, they are locked behind doors, they are not published. गवर्नमेंट को जब आप जाते हैं गवर्नमेंट को डेटा देने कि ये ले डेटा, that's a particular instance of data sharing. Government would rather be in a position to look everywhere and say, अच्छा मैं ये डेटा उठा सकती हूँ, मैं ये डेटा उठा सकता हूँ, मैं ये डेटा उठा सकता हूँ. One DG may not be receptive to data sharing or data acceptance, but a lot of other people might be. अगर आप उसको publicly share करेंगे डेटा को, maybe somebody will listen, maybe somebody will say, oh this makes sense, I'll use that data to publish some research. And it's not just government. आपकी जो government अकेले खुद फैसले नहीं करती ना, गवर्नमेंट आस्क्स एक्सपर्ट्स के मुझे बताएं कि आप क्या करते हैं. उन एक्सपर्ट्स के पास भी वो डेटा नहीं. आप गवर्नमेंट के साथ तो शेयर करते हैं बट यू नॉट शेयर इट विद द एक्सपर्ट्स हु आर एक्चुअली हेल्पिंग द गवर्नमेंट मेक द डिसीजंस. मिसाल के तौर पे सेंटर फॉर इकोनॉमिक रिसर्च इन जो लाहौर में दे वर्क ऑन इकोनॉमिक डेटा. उनके पास अगर पाकिस्तान का इकोनॉमिक डेटा नहीं होगा, दे वोंट बी एबल टू एडवाइज द गवर्नमेंट ऑन व्हाट टू डू. SDPI जैसे ऑर्गेनाइजेशन जो है, they advise the government इसके क्या करना चाहिए. गवर्नमेंट खुद they don't have the expertise. They invite expertise. उधर data sharing नहीं.
We are really glad to have our Vice Chancellor, respected Professor Mohammed Umar, and our Principal of Rawalpindi Medical University, Professor Dr. Jahangir Sir with us. In Rawalpindi Medical University, we have a research culture. And this is the first and only medical university in which there is a separate research curriculum for undergraduate as well as postgraduate trainees. And our university residents, they have e-portals, and all the research they are doing is not on papers, it's on electronics. And we supervisors, we even approve their entries on that e-portal. I will take this opportunity and request our Vice Chancellor to shed some light how Rawalpindi Medical University can be a part of type 1 diabetes registry, at least in the region, and how can we use this data for further technical advancements.
Thank you so much, Professor Umar, for joining us, and thank you so much for giving us the chance to ask you this question. I would really want to, because we're running over time, I would want to start bringing this to a close before we start taking comments from the audience, because I'm sure there will be many comments and questions as well. I would really want you to address this. हम लोगों ने बात की education की in medical schools. How can that address diagnosis for type 1 diabetes at least? हमने फिर बात की स्पेशल केयर की, स्पेशलाइज्ड केयर की, बिकॉज वी हैव अ स्पेशल सेटिंग केयर, बट वी आल्सो नो कि बहुत थोड़े स्पेशलिस्ट हैं. Pediatric endocrinologists, there are very few, just a handful. Yes, it's improving, but it's still much below the mark. We have very few endocrinologists in the country to take care
really good care of people with type 1 diabetes. And when we address this thing, कि हमें ये नहीं मालूम कि पाकिस्तान में इतने लोग हैं जिनको टाइप 1 डायबिटीज है और उनकी एग्जैक्ट नीड्स और उन नीड्स में नेचुरली साइकोलॉजिकल नीड्स भी शामिल है, जिस हासिल में हाईलाइट किया, सवाल में हाईलाइट किया, साइकोलॉजिकल नीड्स भी शामिल है, अवेयरनेस नीड्स भी शामिल है. How can not just our Indian Medical University, yes, that's the first step because we are representing that, but also on in a larger picture, on a larger canvas, how can the medical institutions, the educational institutions, the hospitals, and the government address these issues?
So, honorable delegates, our speakers, our managers, and dear participants, it's indeed an honor and pleasure to be part of this seminar. And I just gathered in the last few minutes. It is not a simple sort of a seminar or meeting or symposium. It is a mission because you are trying to, collect the data. This world is not a data-driven world. This is a world of evidence. This is a world of improved medical practices. And data is the future currency. What I understand, how the world is progressing, it must be data. So the all currency dollar or pound की बात करूँ data currency so लोग के पास कितना data है. Who world use करेगी for commercialization, for saving human life, for education, for social indicators, for key performance indicators. जिस समय के पास data नहीं होगा और जिस बात है उसकी currency में है, आपको की जो so this is the importance I realize. तो दूसरा ये विषय है ये अगर आप टाइप 1 डायबिटीज की बात करें. My mistake aside for the other picture, so I'm not in picture to my understanding not very comprehensive. But I keep talking of the data registry. So जैसे rightly I gathered it is the duty of the information, the duty of the government. क्योंकि जो potential data होता है आप लोग इतने large state पे होता है तो government ही कर सकती है आपकी duty नहीं. तो सिंपल सी करती बात है तो NGO नहीं कर सकती है, एक सोलर यूनिवर्सिटी नहीं कर सकती. आप जब हमारी गवर्नमेंट नहीं कर रही है, हमारे पास डेटा नहीं है, तो वी वांट दिस क्वेश्चन टू बी आंसर्ड. फिर कैसे किया फिर बैठे तो नहीं रहना क्योंकि वो एनजीओ है. फिर हमारी ड्यूटी ये है गवर्नमेंट की मेडिकल यूनिवर्सिटी काम सिस्टम इवॉल्व करे. हमारे पास भी ऐसे एएनएस नहीं है जिससे हम आपको एक इंडिकेटेड डाटा अंडर डेवलपमेंट होता है और वो सॉफ्टवेयर की गवर्नमेंट ने बनाया होता है, गवर्नमेंट टेस्टेड होता है, उसकी कस्टोडियन की बोलती है. अगर वो बदल जाता होता है तो उसकी काउंटेबिलिटी और मॉनिटरिंग की किसी की रिस्पांसिबिलिटी होती है. आई कांट टेक योर अनाउंस डाटा एंड बाद में वो ये वैसे हाउ कैन यू डू दिस, यू कांट डू दिस. ये पूरा इसमें बड़ी डिबेट हो सकती है अभी के चाहिए सब टाइम पर चेंज की वजह से बहुत ज़्यादा बात करें. अब आते हैं सोशल की तरफ. सोशल ये है कि लीग गवर्नमेंट बनाई जो मिडिल आपकी ऑर्गेनाइजेशन का प्रोफाइल क्या है तो दुनिया में कैसे होता है. पीपल वर्क विद द यूनिवर्सिटीज जो एनजीओ तो होती हैं. हमारे दिल्ली याद पड़ता है कि हमारे पास 5 साल से यूनिवर्सिटी में किसी सिंडिकेटेड एनजीओ ने हमारे से एमओयू साइन किया होगा. यदि हम रजिस्ट्री बनाना चाहते हैं और हमारे साथ जो हॉस्पिटल्स भी हैं ये मॉडल है, इस मॉडल में हम एग्री करें वी गेट टू आवर ओन सजेशन और फिर हम वो डाटा जो है उसकी सारे एचआर ट्रेड हो, क्रेडिबल डाटा कैसे होगा, उसका डैशबोर्ड कैसे होगा वो आप एक्सपर्ट हैं. एटलीस्ट राउंड मेडिकल यूनिवर्सिटी आता है कोई एनजीओ भी हमारे साथ काम कर सकती है. हम टाइप 1 डायबिटीज का डाटा आपके 5 साल का लेना चाहते हैं या पिछले 5 साल का लेना चाहते हैं तो उसका क्या होता है. आई एम श्योर पीपल लाइक यू हैव दिस मॉडल. अगर आप ये मॉडल है तो वी कैन हैव अ सेपरेट मीटिंग ऑब्वियसली नॉट इन दिस मीटिंग. We have a 2 or 3 meeting. We can reach to a conclusion कि ये मॉडल है आपके पास या फिर टेस्टेड है कि आप इसमें कौन है और उसके इम्प्लीमेंटेशन और सस्टेनेबिलिटी की ये कॉस्ट होगी इन द फॉर्म ऑफ ह्यूमन रिसोर्स, इन द फॉर्म ऑफ फाइनेंशियल कॉस्ट, मॉनिटरिंग भी होगा, प्रिवेंशन भी होगा. हम उसके साथ मॉडल आपके साथ एडमिशन आ सकते हैं. दैट्स आवर लीगल एंड मॉरल ड्यूटी. तो हमारे 30 लाख पॉपुलेशन जिसको हम कैटर करते हैं हर साल 30 लाख हम देते हैं. मुझे नहीं पता बच्चे 18 से 25% हो गए. उन्हें अगर गवर्नमेंट सप्लाई किया जाए या अगर आईटी मेरी सपोज है कि 3% तो इसका मतलब ये है कि अगर 10-12 लाख बच्चे हैं तो 10-12 लाख बच्चों में से अगर 3% या 2% आईटी है तो आप ये समझ सकते हैं कि 2000 हमारे पास होने चाहिए. तो 2000 के डाटा हम देख सकते हैं और एक सिस्टम कॉल कर सकते हैं As a vice chancellor, I will be the happiest person to do this. Maybe other model, at least let the start, would start. कि हमारे पास 4 हॉस्पिटल है, सॉफ्टवेयर को इम्प्लीमेंट करेंगे, मॉनिटर करेंगे, और जैसे आप कहेंगे आपका भी होगा, एमओयू के मुताबिक पब्लिक शेयर का भी होगा, वेबसाइट पे भी अवेलेबल होगा, वो डिपेंड ऑन But as I'm a social focused person, I do not go by the way city, ये किसका कसूर है, ये काबूना चलेगा, अभी तक कोई नहीं हुआ, not at all. If I have to work with some NGOs, you should do it in your mind. ये model है, I'm 100%, 200% receptive. तो इसको यूनिवर्सिटी कंट्रीब्यूट करेगी. हम नहीं, we are not money earning की company, और मुझसे प्राइवेट में इतने पैसे मिलेंगे, not at all. हमें उम्मीद चाहिए जो हम नहीं कर सकते, जो हम कर सकते हैं वो नहीं कर सकते. Decide the next meeting will be on Monday, maybe on Tuesday, depends on
But inshallah to come back to the solution because this idea has started
when they got to example when they asked me for a अच्छा दुनिया में की रिसर्च हुई है अगर कोई अच्छाई आ रही है वो मॉडल हो तो वो भी यूनिवर्सिटी की तरफ से आ रही है अगर कोई सोशल चीज आ रही है तो यूनिवर्सिटी से आ रही है अगर कहीं पे क्रेडिबिलिटी एस्टैब्लिश हो गई है यूनिवर्सिटी अगर रिसर्च हुई है मुझे आज तक पाकिस्तान में समझ नहीं आया कि एसडीओ के साथ काम करते हैं एंड दे हैव नो एमओयू विद एनी यूनिवर्सिटी छोटे मोटे मॉडल के 5 साल से तुम्हारी रिसर्च अगर आप यूनिवर्सिटी के थ्रू करेंगे ये पढ़ा के लिखा कल ये पॉजिटिवली किसी को भी काम आए लास्ट की लाइन के स्टूडेंट के भी है बेटा बैंक पिछले साल आरएमपी बेटा आप आज आईटीएम का करना चाहती हैं तो ये 100 साल के लिए पढ़ाओगे सिस्टम ऑफ रिप्लेस करती है हम आपको डेली का डाटा दे सकते हैं अगर कैटेसी का डाटा दे सकते हैं क्योंकि हम सारे अटेंडेंस को नहीं देंगे there are so many models but we need a separate thank you last week thank you
when you signed that with Ultimate University, which is for digital libraries. He is an exception. We signed and we would meet.
I'm not aware of this.
Sir, we have evidence. You are standing there. Can we put that slide on? So we always made in the start. The program does a lot of things and that is okay. That is fine.
But this shows our interest. If I've signed this agreement, so I've not taken a single minute.
Thank you so much for doing that, and I would again thank American University for not only supporting this event here today, but also taking the first step towards digitizing various aspects of healthcare, which is very important as part of today's solution. I would like to just take a last comment from the principal of American University about how can we integrate type 1 diabetes in the medical education curriculum. Data suggests that there is 46% early mortality with type 2 diabetes. 1 in every 2 people passes away early, either because of misdiagnosis, lack of diagnosis, or because of cancer.
Bismillahirrahmanirrahim. Thank you for giving me a chance to speak on this important topic. As already Dr. Inas said, our education is integrated right from the first year. If the diabetes mellitus is being taught to the student, he is shown that not only physiology will be taught, pathology and disease of diabetes will be taught. Everything physiology, pathology, anatomy, integration is present, and even he is given the different addresses for research on that topic. So already we are doing our job. Right from the first year, we have up to final year integration is present. And definitely when these students will come out, they knew about the importance of diabetes mellitus type 1. And lastly, the thing I want to say in front of so many experts, and I really humble to say this, that our problems can be solved by ourselves. If we want to import us during a practical management of the thing, it will never solve our problems. We have a different setup, we have a different society, we have a different people who are different genetically, whose behavior is different, religion practices are different. So we have to, in the end, generate our own model, only then we will be successful. Thank you.
So, are we holding meetings in India?
Inshallah, I would like to invite both for Pakistan for that meeting because we need their help in developing this. Shall can I take the thank you so much for this. So, one
दूसरा मतलब ये इस तरह से मैंने बहुत मीटिंग अटेंड की है और ये एनजीओ जो है वो अपना मीटिंग करवा रहे हैं बट आई वांट के एमओयू जो इसका हिस्सा है वो टाइम लाइन शुड बी देयर और फिर इसकी पहले मीटिंग होनी चाहिए और एक फॉर्मा जो है गूगल फॉर्म पे सारी चीजों को और वो डेटा के साथ एक लाइन चार्ट के साथ इसका क्या आउटकम है और मेजरेबल आउटकम टाइम लाइन के साथ आने चाहिए तब हमारा फायदा होगा अदरवाइज कोई एमओयू
So the good thing that today's meeting did was, and that's not data available.
You are right, President.
Yes, sir.
So ये सैलरी हमारे तरफ से
Okay.
तो ये सारा काम और क्या काम हुआ हुआ है और अक्सर कॉन्टैक्ट किया है तो मुझे को आप पूछ लीजिए थैंक यू वेरी मच
Thank you so much. So the good thing that today's discussion did was the idea यहाँ पर generate हुआ कि ऐसा platform होना चाहिए या फिर इसकी endorsement. Thank you so much.
Thank you
I make a maximum of 3 comments or questions to our esteemed panelists now before we wrap this up and start with.
Can I just ask him to comment on something because Asim has been involved in a lot of policy level decisions.
Asim, you were hiding away. Asim did not inform that he's coming and I told him कि हमारे ग्रुप में जो silence है that is harm and use. So thank you so much for coming. Your silence, I think I read your silence correctly. Thank you so much. Asim,
So for this kind of like this conference, my introduction is that I'm a former president of Photo Pakistan, or some of the work that was done when I was the president. One of them, probably you all know, is Citizen Portal. So Citizen Portal was government अपना idea था स्टूडेंट शुरू में खुद ही काम किया था, but जब वो nationwide launch हुआ, उसमें कुछ challenges थे. So हम as a citizen, we used to like support them and we made it up and running. And think of Port for Pakistan because I'm assuming a lot of people are from medical profession. We are just like doctors without border, but we are not doctors. We are not working without border. We are working inside Pakistan, and we are software engineers and social scientists and other specialists. Just to see as a citizen how we can support government do what they should be doing for us. So that's kind of like the gist.
Thank you so much, Asim, for joining us today. And Asim has been an ardent student of SSA and Facebook connectedness, probably the first or the second time that I'm meeting you here today. Thank you so much for joining us. I would take 3 comments from the audience and questions before we end this discussion. Our worthy guest of Ramya team, thank you so much for joining us. Dr. Tai Zaidi, my teachers, or what you really respect, we have run late on this event. They are here waiting for us to move towards the vote of thanks which we have to do today. A lot of people who have supported the work that we saw in the document today. 3 questions. Yes. Right, pharma industry here. This is a comment for you. We have no one on the stage, but I'll just ask you to please note this down. Yes, Glucagon is not available. बहुत सारे बच्चों को severe hypoglycemia होता है, liquid hypoglycemic effects. Vicky was talking about this. Happened to her son in the UK. It has happened to me at least 5 times in my life. When I completely like basically I खत्म है. Falak Khan talks about it in one of his videos, which I'm just going to play right now after this. So this is a need, and it needs to be addressed. Thank you so much. Any other comment?
Can I ask a question? Yes. We tried one of the reasons I invited Asim Moore was हम लोग बात कर रहे थे कि गवर्नमेंट को इन्वॉल्व होना चाहिए, गवर्नमेंट को ये काम करना चाहिए. How do we get the government on board? What do we need to do in terms of policy making, what do we need to do in terms of strategic planning, what do we need to do in terms of providing enough information to the government to help them help us, to help them raise awareness for either diabetes or get the electronic medical, जो हमारे electronic medical records हैं, they are not our own property, they are property of the hospital. उनके लिए हम क्या कर सकते हैं? What do we need to do to make sure that that happens?
Anyone would want to answer?
Okay, so yeah. So again, unfortunately, जब service delivery की बात हम बात करते हैं, तो it's kind of like designed जिसका 100 years पहले थे. एक मैं example देता हूँ, let's say उन्होंने वो pregnant है, तो ideally service delivery should be एक pregnancy से लेके जब तक बच्चा 9-8 महीने तक जब तक वो पूरी health care नहीं होती, there should be one window जहाँ से उसकी सारी services मिलते हैं. But अभी people को कोई भी चीज़ हो जाए, health program आदि कोई भी है, people run between different departments to get that thing done. प्रॉब्लम क्या है कि हमारे यहाँ जो गवर्नमेंट डिजाइन में ये वो एक प्रॉपर साइलो की गवर्नमेंट डिजाइन में है, people hold on to data, they don't want to share information with each other. शायद सिटीजन के साथ वो फिर भी शेयर करते हैं, आपस में ज़्यादा उनको मसला होता है कि हमारे साथ हो कि हमने एक पोर्टल बनाया, गवर्नमेंट के बॉडी डायरेक्टर इसको बंद करवा दिया कि उन्होंने क्यों बनाया, हमने क्यों बनाया, तो हमारे जैसे कि इशू इसका तरीका जो सॉल्व सोल्यूशन है वो what we have found is afford one is policy. You always find some तगड़ा minister in any department, planning हो सकता है, finance हो सकता है, who understand that maybe for some personal reason and he says okay I will put my effort. जब हम मोदी भी जब काम कर रहे थे तो हम finance ministry से भी support किया and so on. तो कई बार वो right ministry को होता है, आपको किसी और की ऐसा बंदा जिसके PM के साथ बहुत strong है, community service ट्रांसफर है, वो कहेगा नहीं this is the right thing to do and I will. दूसरा तरीका क्या होता है कि हम नीचे वाले लेवल पे जब आप जाते हैं किसी की ऑफिस के द्वारा मिनिस्ट्री फाइनेंस है या आईटी मिनिस्ट्री है, तो you generally find some people somewhere who are like-minded. So हमारा भी रूट डिफरेंट विश हो सकता है, कोई भी हो सकता है, जैसे मतलब पुलिस का आईटी हो सकता है, किसी गवर्नमेंट हॉस्पिटल का आईटी हो सकता है. When we see a like-minded person, we out of the way we try to go and see how we can make that person look good. Because if that person looks good in front of others, peers, that will incentivize others to do the same type of behavior. It's like data की हर कोई बात करे, मैं भी data पे. So I think sometimes we as a citizen underestimate how we can actually kind of like accelerate the goods in the service delivery side, and so that is kind of higher. And once this is solved, so this is of course not a policy. Policy again, you learn from this and then you talk to the right person who has the ears of PM or president or.
So, I have a question.
So thank you for your wonderful comments, and we all were here to find some solutions for this thing. So we know what government can do, what they can't, and we are having this debate given why. But we all know that there is a movement for diabetes movement. We are not waiting for it, and they did a miraculous job globally. And why can't we? So it's not only about a closed loop system, but also maybe we have diverse audience here, so that tech or the telecom industry could put a message on the ringtones like they did in COVID, so to aware the society, so they get to know what are the symptoms and signs. Maybe there could be another message for people with type 1 diabetes, because we all use cellular cell phone and all that. Apart from that, what you can do as a person living with type 1, we can't wait for government, we can't wait for some organization to make a server or something, software for us. So why can't we make our Facebook accounts, we can also put our own data over there, so that we can do, but we need some portal for it. So if somebody could just do that, that will even make a big step.
Thank you for this wonderful idea. I really want to close the panel here and someone wants to comment.
So I just want to quickly comment something. So those if I had ringtone wali is mentioned with me. By the way, that was again a volunteer program. So the initial idea था वो एक voluntary university में. Then there were some companies who rented their resources to develop जो पूरा का पूरा है. उसकी जो English to Urdu translation हो रही थी, उसमें भी जो लोग थे वो भी volunteer थे. Of course, they found a champion in government.
When there is a will, there is a way. We have so many.
But he क्या थी कि they found a champion in government जो उसका इंतजामिया थी, who actually helped them and get it के PTA regulator was supporting. But जितना पीछे work करना था. So I think diabetes पे भी अगर right advocacy to right people think to afford, I think perform highest number पे so शायद
third.
so that can again be.
Thank you so much. Yes. definitely pertinent or okay, Sara has a question. I'm sorry, Dr. Amrit, मैंने आपको promise किया था कि I just keep you here for half an hour, but I think this is very interesting if people want to comment.
I just have a small comment. We're working as volunteer group. I'm president of Federation Club Pakistan, and we support females at different areas. We go from areas to the economic as well. So we are here to support in any way or any form, but we actually don't know how would we be able to do that for you guys. You can connect to us. My number is Vidana. You can connect to us.
Thank you so much for the offer. Hassan, Adventure Club supported our camp. You were not part of that, but हमें type 1 का camp लेके गए थे नशा करके हम लोग camping करवाई थी, actual camping. And it was a scary thing because हम सबको ये डर लगा था कि कोई हाथ हो जाएगा, किसी का हाथ हो जाएगा. But it was beautifully done, and thank you to Hassan Adventure Club for supporting that. I think we need to think more about these things because बच्चे भी कुछ पूछते हैं दोबारा कर जाते हैं. Thank you so much. There's a question or comment from Savi.
जी सलाम साथी फ्रॉम सेंटर मुझे महीने पहले तक नहीं मालूम था डायमंड डायबिटीज का एंड आई मेट सना अहमद एंड दैट्स सेपरेट हमने फॉरेन वाले पे पॉडकास्ट कर रहे थे वी आर सेपरेट कास्ट और उस पे वी गॉट द फीडबैक लाइक पीपल स्टार्टेड रेस्टिंग नहीं ये सब कुछ सुन के लग रहा है कि ये सिंपल तो हमें भी है या हमारे बच्चों में भी है First of all, really grateful to the meetings in the awareness of the platform that is generating. Kudos to Yasin sir on the stage as well. These are doing a tremendous job. Comment मेरे सिर्फ दो में और छोटे से हैं. First के डेटा पे कोई भी काम होगा तो I'm representing separate here तो अगर इमरान साहब को या डॉक्टर मुख्तार को जरूर उसमें इनवाइट कीजिएगा. We are very interested. एग्री साइड पे भी काम कर रहे हैं डेटा में तो थोड़ी उससे समझ नहीं है. सेकेंडली यहाँ जितने डॉक्टर्स बैठे हैं इट्स जस्ट लाइक कि आप डॉक्टर से डेटा का एक्सपेक्ट करें लाइक कि डेटा से आप एक्सपेक्ट करें कि वो आपको मेरा इलाज करें. ठीक है तो एक इकोसिस्टम की जरूरत होती है. बट आई वुड कमेंट कि ओवरऑल बोथ इश्यूज में डायबिटीज के बैठे आई एम ग्लैड कि आपने टॉपिक हेल्थ केयर रखा है इस बारे में नॉट डायबिटीज का. तो ये सारे डॉक्टर्स माशाल्लाह बैठे हैं ये बहुत से इश्यूज पे काम कर रहे हैं. तो होना ये चाहिए कि एक माइंडसेट हम सब एक रेडी करें. द माइंडसेट इज कि सिस्टम शुड वर्क. ठीक है तो वो डायबिटीज हो वो जिसमें हाइपरटेंशन है ये कोई भी इशू है हमें अपना गोल अल्टीमेट विजन ये रखना है कि सिस्टम ऐसा बन जाए कि ये सारे इश्यूज गवर्नमेंट की सपोर्ट से सिस्टम की सपोर्ट से सॉल्व हों. इन द मीन टाइम एज सेपरेट एज होप फॉर पाकिस्तान या एज हेल्थ केयर प्रोफेशनल या आप जिस कॉज को चैंपियन कर रहे हैं करते रहें. देयर इज नो हार्म इन दैट. लेकिन अगर ये माइंडसेट ही खत्म हो जाए कि गवर्नमेंट ने कुछ नहीं करना है नहीं कर सकती ये सिस्टम कुछ नहीं कर सकता तो अल्टीमेटली ब्रॉडर लेवल पे आप बड़ी पॉपुलेशन की कुछ नहीं कर सकेंगे. तो माइंडसेट अगर मेरा कमेंट ये माइंडसेट अगर हम रखें अल्टीमेटली हो और अपने डोमेन में जो जो काम हम करते हैं वो एक दूसरे को थैंक यू.
Thank you so much, sir. Yes, thank you so much. The ecosystem development, ecosystem is very important. And probably that's missing. इसकी वजह से सब कुछ हो रहा है कि हर कोई अपने साइलोस में डेटा लेकर बैठा हुआ है and it's not being shared and it's not reaching the right players at the right times. We need to address that together. And thank you so much to our panelists for this very insightful discussion. I would request you to stay on stage. I'll invite our board members of Ramit Inu. He's the Dean of Custody University. Samin Ramit, thank you so much for joining us. Abu Basir, President of Meeting Zindagi, and Dr. Amir, Dr. Asim Rashid, please come over for this vote of thanks. And I will now hand over to Mufara. Oh, sorry. I have one little request. So there's a very young little child, and he wants to talk to us. His name is Subhan. Right, Subhan? कितना मिनट है? एक मिनट.
अस्सलाम वालेकुम. ये मैं सबसे पहले अल्लाह ताला का शुक्र अदा
ये जो शुगर है ये कोई बीमारी नहीं है, ये एक लाइफ स्टाइल है। थैंक यू।
कहाँ से आए हो?
हम दिल्ली में नहीं, हम मुजफ्फरपुर से।
Thank you so much. Thank you. Your family, please.
We should begin with thanking Professor Umar, Vice Chancellor of Rawalpindi Medical University, for his contribution to care of people with type 1 diabetes and this event. Abdul Basit, could please present a small green gift to Dr. Hina Sattar. Please, if you can receive the humble token on behalf of Professor Umar.
I will be calling you back. This idea also came from Code for Pakistan. We wanted to do something green. And these small plants are part of our commitment to for this data as well, क्योंकि वो पेपर से हमने जान छुड़ानी है और अपने environment को green करना है. Thank you to Code for Pakistan and to Ashar who is bringing in a lot of ideas from you people to us.
Shakti and Umar, thanks a lot for sharing your insights. We look forward to working with you for building data systems. Dr. Amir, you please present the token of sharing. Dr. Hina Javed, who traveled from Lahore to take part in this event. Dr. Asif, please present the icon of growth to Dr. Hina. Dr. Hina Sattar, who not only looks after a lot of very cute little members of our community, but she's always been a beacon of progressiveness. So, Dr. Sana, please present a token to Dr. Hina.
God, I'm very much fond of your gardening. I think I will. Picture. Please send them out.
Abbott, for supporting our community activities throughout the month of November. I would request Amir Aziz to please come on stage. Amir Aziz.
Do we have someone from Abbott?
Sanofi for supporting the World Diabetes Day. Any representative of Sanofi? Okay. So let's start with someone many of us don't know, but someone who has been an ardent support since we started. That's TCS. So please, if we have any representative from TCS.
Mehtab Bhai, do we have you here? Mehtab Bhai है यहाँ पर? So Mehtab Bhai is a rider जो हर दूसरे दिन हमारे ऑफिस आते हैं इंसुलिन के डब्बे उठाने. We wanted to acknowledge him today. Shiraz नहीं आए? अच्छा कोई बात नहीं. So आप लोगों ने ये जो है वो मेहताब भाई को पहुंचाना है. We wanted to acknowledge him. पहले दिन से वो हमारे पास आ रहे हैं. He has been a huge advocate. वो जिस प्यार मोहब्बत से उन डब्बों को अपने सामने पैक करवाते हैं और डिलीवर करवाते हैं. Hats off to him.
So moving towards the Charity Wings Foundation that has lent us their immense support in carrying out logistic operations in flood affected areas. So Hemant could not be here today, but I would invite Tosif and Aisha to please receive a humble token.
Charity Wings Foundation volunteers को डॉक्टर्स को बोट्स पे ले जाती रही है to every house. To knock on the door and ask कि इस इलाके में कोई टाइप 1 तो नहीं है जिसको इंसुलिन की जरूरत है. Huge work.
Digital Pakistan Lab, Dr. Tahir Sedi, ENE College Naz, for supporting development of our beneficiary management system. A very important step towards documentation and database learning.
I
helped us develop a system, जिस ecosystem की बात कर रहे थे, that's just for Meeting Zindagi, but something like that can be extended to the country with multiple centers taking part. Thank you so much, Dr. Tariq, for helping us out.
Receiving that, Dr. Badrul Islam for providing free HTML for some children and subsidized cells for the rest.
Mother was here a little while ago. I think he was tired. We took too long. We'll send him.
So to time apps for subsidized HTML tests for children, we have 3 representatives from Thailand.
हमारे मॉडल को सबसे ज्यादा इस चीज ने सपोर्ट किया कि इनकी लैब्स हर जगह मौजूद थी एंड वी कुड सेंड द किड्स टू देयर लैब्स टू गेट देयर टेस्ट डन एंड दैट सब्सिडाइज्ड रेस. थैंक यू सो मच.
Dr. Talat from Kamaran received a token for supporting 12 children for over 3 years now. और मैं एक और बात बताऊंगी, जैसे डॉक्टर सना ने पहले बताया कि डॉक्टर नीति जो है वो ब्लू मामा है, सो ऐसे डॉक्टर तलत है ये भी ब्लू मामा है. Sathi from Cyber to support awareness and learning.
Sorry for interruption. Dr. Talat joined the Iron Lady, who has inspired me even कि इन्होंने जितना सपोर्ट किया है इस कम्युनिटी को, इतना स्ट्रॉन्ग होल्ड दिया है. I think I just even by looking at her I feel inspired. So may God bless her. Jazakallah khair.
इसके वालिद होते तो बहुत प्राउड करते मुझे भी बुला दिया.
Sathi from Cyber to support awareness and outreach. Sabah Tanvi from AIMS, who has traveled all the way from Peshawar. Sabah, please come here and receive the token for becoming the first digital library education center in the country. Sundar and Farhan for filming the beautiful documentary and working with us since we started, when there was just one child being taken care of. Dr. Javed, Medical Director of Pakistan Baitul-Mal, for his commitment and support for children with diabetes. I didn't see her, sir. Dr. Abid Hori, Program Director NCD. Okay, for Rawalpindi Chamber of Small Traders and Industries, we have Naeem Ashraf. Sorry, I think हमने कुछ ज़्यादा ही टाइम ले लिया. Okay, so Mr. Naeem Ashraf and Dr. Arif from Amazing Zindagi Lions Club for their support.
I think they've left. Sorry.
So Dr. Shahreen Zahid, yes, she's from Adventure Club Pakistan, and they support us in diabetes adventure retreats and rallies. Easy Shiva for them to help us establish systems that can make access to a healthcare provider possible in very remote areas. So I would like to invite Dr. Adnan.
I'll just add a word to this, and we are going to develop a solution with them for providing accessible medical care. Thank you so much. They have a stall outside. They're presenting their very innovative solution. I would want you all to please visit that on your way back.
I would also like to mention the doctors in the audience supporting children and young people with diabetes. Thank you for attending the session today. I have one very special announcement. So I would request Anam Anwar to please come on stage and Rabia Haji. So Rabia Haji and Anam, they are the employees of the year 2023 for Meethi Zindagi. The most important people I cannot call on stage at the moment as they are busy being the hands, feet and backbone for Meethi Zindagi, our great team and peer leaders and volunteers. Thank you so much.
Before we end our video, we'll just take 5 minutes to play that and then we go towards a group photograph and
मैं 17 साल का था and my body went through an autoimmune एक response हुआ and I don't know if there's a better way to explain it and I think a medical expert could explain it better. Insulin बनना बंद हो जाए तो उससे आपकी blood sugar जो है starts elevating and that's called diabetes. So मुझे type 1 diabetes है and at the age of 17 मुझे एक बहुत तेज बुखार हुआ तो उस तेज बुखार के बाद I lost around 10 kilos of body weight in a matter of 8 days. I used to be 65 kgs and I went down to 55 kgs at the age of 17. And then the next day, I think after that, मेरी प्यास बहुत ज़्यादा बढ़ गई. There's a condition called polyuria, which means you are frequently going to the bathroom and you constantly have the need कि आपको बार-बार पेशाब आता है क्योंकि आप बहुत पानी पी रहे होते हैं. तो मैं 6-6, 7-7 लीटर पानी पीता था और मेरा मुंह हर वक्त खुश्क रहता था. So I was dehydrating. उस वक्त आई थिंक स्पेशलिस्ट थे लाहौर में लेकिन वी जस्ट वेंट टू माय जीपी उन्होंने मेरी ब्लड शुगर टेस्ट की बिकॉज ही सॉ द सिम्पटम्स एंड माय ब्लड शुगर वाज एट अराउंड 600 एट द टाइम so then I was checked into the hospital and then I was rehydrated and I was given insulin and I have been on insulin since the age of 17 और आज मैं हूँ 41 साल का 41 का so it's been a career in diabetes for 24 years लोगों को जो है नहीं पता कि क्या इम्पैक्ट होता है बस वो शुगर है तो है but it can be a harrowing experience. I think there is not much awareness. पोलियो के लिए अवेयरनेस प्रोग्राम्स होते हैं ना तो डायबिटीज के लिए अवेयरनेस प्रोग्राम्स क्यों नहीं है? I think for the first जब पहले 2 साल हुई थी तो पहले 3 महीने 4 महीने तो मैंने कंट्रोल की and I was in A1 when that happened. But then when I got into A levels जैसे जैसे गुजरता गया I stopped caring about it. I'll be very honest. I would have soft drinks all the time because I was angry. I was like, I want to live the same life as other people. Why should I suffer? It's better you take care of yourself because you're going to have to live with it. So मैं कह रहा हूँ school के environments को जो है we need to make them more conducive to be inclusive. जो मुझे लगता है जो ज़्यादा ज़रूरी है वो ये if it is a disability then own up. You need to admit to it, not hide it from the world. बहुत दफा ऐसा होता था कि लोग कहते थे तुम ना बताओ कि तुम्हें डायबिटीज है मैं कहता था क्यों क्योंकि लोग तुम्हें शायद कम समझेंगे कम like they'll think less of you they'll think you're not able to do things I think I can do a lot of things feel proud of it I would say don't feel down and don't discriminate this don't be embarrassed of it बताएं आप लोगों को कि मुझे ये बीमारी है उस जमाने में तो ये होता था कि शीट्स होती थी ना तो हमें 6 खानों की शीट मिलती थी प्री मील पोस्ट मील दोपहर के सुबह के नाश्ते के वक्त पहले क्या रीडिंग थी आपकी फास्टिंग उसके बाद आपकी रैंडम क्या है फिर दोपहर के खाने के वक्त तो ना वो एक पूरा आपको चार्ट पेपर मिलता था और मैंने तो कभी आज तक नहीं भरा बिकॉज इट वाज अ टीडियस टास्क टू फिल दैट स्टफ अप सो यू prick your finger 6 times a day right so I'm just saying that up to here there are better things I got into CGM back in 2014 now I'm using Abbott ka Freestyle Libre and I think it's a good device and it's great door-to-door service as well. So I'm using that. उसमें क्या होता है कि you wear this sensor on your वो आपकी स्किन के साथ लगा होता है आप बस एक जेब से रीडर निकालते हैं टच करते हैं आपको आपकी रीडिंग पता लग जाती है so you're free of pricking yourself. अगर आप अपनी उंगलियों पे ज्यादा prick करें राइट तो they start becoming calluses बनने शुरू हो जाते हैं और उसमें छोटे-छोटे डॉट्स आ जाते हैं अब तो खैर ये सारी की सारी फिर then it heals when you stop pricking then it heals. But if you can tell by the fingertips कि बंदा अपने आप को कितने दिन में prick करता है because उसमें छोटे-छोटे काले-काले डॉट्स होते हैं बहुत सारे there's just micro wounds in there so it's just a lot of paraphernalia यार मतलब ये होता है ना कि आप उठते हैं और आप कीज अपनी पॉकेट में डालते हैं और वॉलेट डालते हैं। मैं इतना भुलक्कड़ आदमी, मैं दरवाजे तक पहुंचता हूँ, मुझे बोलता मैं अपनी इंसिडेंट भूल गया, अरे यार मैं मीटर भूल गया, अरे यार मैं ये भूल गया। अब उसको कैरी करने के लिए एक अगला से बस्ता चाहिए, लाइक बोरी चाहिए। सो लाइक इट उस जमाने में वेरी इनकन्वीनियंट थिंग, लाइक you just couldn't be mobile and just walk around or something like that. But again, there's solutions to it. Always remember के limitations जो होती हैं and adversity breeds creativity and breeds innovation and it breeds success. If you don't know the downs in life, you'll never appreciate the ups. So the more down you are, when you go up, उसका मजा भी और आएगा. So आप इसको इस तरह सोचें. I just feel when I look back at these things, for me, ये भी एक story of survival है. And वो कहते हैं ना ये दुनिया is the survival of the fittest होती है यहाँ पे. So I think that survival of the fittest does not necessarily mean that you have to be physically 100% fit. मतलब I feel it's the fittest are the people who are fittest here. इसका ज़्यादा ख्याल रखें और फिर ये जिसको कहते हैं ना mind over matter, वो बाकी चीज़ों का ख्याल करेगी. अगर आप ये चीज़ फेस कर रहे हो, especially the primary caretakers, there is a way forward. And दुनिया में और बहुत बड़ी ट्रेजेडीज हैं. ये कम ट्रेजेडी नहीं है, बट बहुत बड़ी ट्रेजेडीज हैं. सो हैंडल इट विद केयर, हैंडल इट विद लव. यू विल, आई थिंक, टॉप. एंड व्हेन यू कम आउट ऑन टॉप, यू विल हैव समथिंग टू बी प्राउड ऑफ. मैं आप बच्चों से मैं बात कर रहा हूँ. आपकी क्लास में अगर बाकी 10 लोग हैं, आप अपनी जान जब बचा रहे हैं, यू आर डूइंग दिस एवरी डे. सो यू आर एक्चुअली स्ट्रॉन्गर देन द पीपल अराउंड यू. सो डोंट लूज होप. यू आर द हीरोज ऑफ योर लाइव्स. देयर इज अ लाइट एट द एंड ऑफ द टनल.
Join us for a group photo. The stage is outside. Join us for the refreshment as well in the exhibition area. और exhibition area में you will witness amazing artwork. और मजे की बात उसमें ये है कि जितना भी artwork जिन लोगों ने हमें भेजा है, they all are living with diabetes. So please, thank you so much for joining us on World Diabetes Day 2023. Let's continue working for a future where everyone have the access to the care they need. Thank you so much.